Welcome everybody to the meeting of the Royal Cornwall Hospitals Trust Board held in public this morning. It's very good to see everybody here and lovely again to have members of the public joining us. We really appreciate that and your feedback. Just to let everybody remember, the meeting is live streamed and a recording of this meeting is on the Trust YouTube channel for a month after the meeting. For members of the public, Teams Live has the feature of live subtitles and you can be accessing them by clicking on the icon on your screen. Any comments that members of the public have, we really do welcome and can be sent to the company secretary, rcht.corporategovernance@nhs.net. And the other option is there's a survey monkey which will get posted at the end of the public question and answer session. Just very briefly to remind us of etiquette for the board, muting our mics if we're not speaking, use the chat function to indicate that we wish to speak. Please assume when introducing a paper that board members have read it, so highlight key points to maximise the time for debate. We'll put questions once the speaker is finished and I'll do my best as usual to cluster them so we can work more efficiently. We are all trying really hard to avoid the use of acronyms, but there is a glossary of terms at the back of the pack. And we'll take questions from members of the public at item 18. If you do have questions to raise, please raise them on the MS Teams function, and they'll be reviewed by our company secretary as per the protocol, which is set out in your agenda. There'll be a maximum of 15 minutes allocated for questions. The company secretary will ask the question on your behalf and I will seek a response from the relevant director. If we can't get a response, there will be a written response included in the minutes. We're going to try to work swiftly today because, as ever recently, we have got a lot of items on the agenda, but we will take scheduled breaks each of 15 minutes around 11:25 and 1:05. The meeting will be concluded at 2 o'clock. We have received apologies for absence from Susan Bracefield, Chief Operating Officer, and we have Robin Jones, Acting Director of Operations, in attendance, from Sarah Price, Non-Exec Director, and from Rich Smith, Associate Non-Exec Director. So that brings me, I think, to item 2. Are there any declarations of interest in relation to any items or any other amendments to the register of interests from anyone? And I'll take silence in this instance as a no, so speak up if you, okay, we'll take that as no. That brings us to the minutes of the previous meeting, and I want us, if we could review them and matters of accuracy only, and also approve the previous minutes, the meetings held on the 7th of January. So if I can go through page by page, I have one on page 15 and it's for Alistair, so I'll raise it when we get there, Alistair. So page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, great, my one on page 15 is just Alistair, it's the 20.163D1, the training for doctors. I'm sure this has happened, I just couldn't find it. It said that the training for doctors was sent to all consultants. Do we know whether they've completed that? And there was going to be delivery by the end of January of the online, and was that delivered, please?
So there were 2 sessions for doctors and other staff set up in January, and 2 sessions set up in February for learning disability and autism training. So those have the January ones have happened. The February ones are happening in February, so I can confirm that that's the case. The online training for learning disability has also gone live, but it's in a preliminary form and needs some work still. So that's an ongoing piece of work with the L&D team, but it is in there in a preliminary form. Yes.
That's great. Thanks very much, Alistair. So that then brings us 16, 17, 18 and 19. Tom, 18.
I've got a point, Murray, but Kate was there first. Actually, Kate was putting her hand up.
I'm really sorry. I haven't got an electronic hand, so I'm going to have to put an X in the bar. I was just wondering, doesn't come up as a matter of rising, I don't think. But I wonder, Kim, whether you want to update about our first milestone for the Never events and the return that went in on the 31st of January.
Sorry, Kate, I'm just unmuting myself. So is this, do you mean in regards to our submissions?
Yeah, because the outcome letter and now the explanation of what happened next is in the minutes, but we haven't got it on the agenda, and we've hit our first milestone on the 31st of January.
It's in our committee agenda.
Right, thank you.
Thank you.
Thanks, Kim. Tom.
Thank you, Murray. It was an accuracy point, I think, on page 16 of the minutes that I've just seen, under the maternity incentive scheme relevant to CNST. So under A1, it says CNST was suspended during the pandemic. I think it was the maternity incentive scheme or the reporting against it that was suspended, not CNST itself, which I think is a key difference. Perhaps Kim could just clarify that, but I believe that to be the case.
Yeah, it's the reporting itself which was suspended.
Yeah, not CNST.
Not CNST itself.
Thank you, Tom. So, Sian, you'd be good enough to correct that in the minutes, please. Are there any more material points? In that case, are you content that I sign these as an accurate record? I'll take silence as a acquiescence in this case. Thank you. Thank you, Paul. Okay, that brings us to the action log. And again, in the interest of time, you will see that there are notes on the action log. So do ask any further questions you have other than what is noted. And if I just go through one by one, I sent the letter and had a very charming response from one of the people, which was really nice. This was the letter to congratulate the costings team. The second I'll update you on in my report slightly later in the agenda. This is going to be addressed in the Q3 report, the learning from deaths. The consideration of risks is proposed complete. And no material change. Just stop me if anybody wants to say anything. The integrated performance report is in progress and there is an update there, which you can see. Risk management strategies proposed complete. And we did discuss it at the board informal. I'll say a bit more about that. The learning from deaths, there is a series of updates there. The Guardian of Safe Working Hours is in progress and with a revised date to March. And you also have updates there. Does anybody have any further questions or queries on those? Okay, thank you. In which case, Kate, may I ask you to make any points or introductory remarks you wish to raise, and then I will do the same. If I could just let people know, I actually can't see many of us on the screen, so if you need to speak, will you put an X in the box, please? Thank you. Over to you, Kate.
Thanks, Mary. I just wanted to start off with some feedback that the whole of the NHS has received from Simon Stevens and his senior team in NHS I&D. And just they've been massively impressed by the response of the whole of the NHS and indeed the wider public sector during COVID. And for our people in our hospitals, I think it's important that they hear that message, and coming via the board, I think that's probably a very good way of delivering it. We've continued to be very busy still with our COVID response, plateauing out at a level that keeps the hospital very busy. So most days we have around 22, 23 people in our intensive care unit, which if you will all remember that we commissioned 15 beds. So we are very firmly into our green surge response. We have been able to be keeping most of our hospital services running, although once or twice this week we've cancelled cancer operations. But I have to say I'm really impressed with the clinical engagement across the trust, and also with Cornwall Partnership Trust, with our clinicians working together to make sure we maximise all resources in Cornwall to make sure that we're able to look after our most vulnerable. And to that point, for our board, I think it's also important that we notice and acknowledge the massive work that the whole of Cornwall are doing to make sure that we're managing people in their place of choice, which often is their own homes. So we're supporting a large number of care homes, and between us, the independent sector and the voluntary sector, social care, and we are working together in a way that you'd expect an integrated care system to work together. So we are starting to do what we've been planning to do, which is great. Our planning for 2021 will start soon, so this will be a year of recovery. There's a lot of conversation nationally about us allowing our staff to have some time for rest and restitution before we start working people very hard again in terms of picking up the waiting list that we've got and making sure that we are getting back to a position that we were 18 months ago. We're going to be asked to look at how we bring a team of people together from all statutory agencies, so as CFT, the CCD and the council, so that we've got one way of making decisions about the 2021 planning round. And Paul and I were on a meeting yesterday with the start of looking at how we'll do that, and we're hoping that we'll have that in place for April. We've had the first cut of our staff survey back, and we'll be formally presenting it to the committee and to the board in March. But the two metrics, as you know, I'm always really bothered about. One is, would you recommend here as a place to work? The other one is, would you recommend this here as a place to be treated? And overall, our response rate raised by 3%, so 59% of our people told us what they thought. That's good because we employed 600 more people. So in overall terms, more people are telling us what they think. And recommending as a place to work has gone from 58% to 64%, and recommending us as a place to be treated has gone from 61% to 69%. So it still makes me wonder what the other 36 or 31% think would make us even better, but it certainly is a massive step forward to us becoming the hospital that we want to be. We're starting the process of updating our board freedom to speak up self-assessment. We did a draft, you'll remember we did a draft self-assessment in November, but we'll need to bring that back through the March meeting so that publicly we're letting everybody know where we think we stand based on the feedback from our staff, our freedom to speak up champions, and our self-assessment of how we think we're doing, becoming more of an open organisation. And I think that probably is it for me. Just to finish with, we still are incredibly busy. We have got amazingly flexible people being redeployed into scary places like intensive care, who are being received by staff in those areas with such, well, I don't know, gratitude and loveliness. And there seems to be a big kindness campaign going on our Facebook. If you're not on RCHT's Facebook page, I think you should join it, just for you get a bit of lovely humanity around. I'm really scared to go to X. You were great. We really appreciated you. It's really good. We're all working together. So I think our people are doing a fab job.
Thank you, Kate, for all of that information, and just, you know, to echo your celebration of what people are telling us, and it would be lovely if they told us more. And what a great note to end on, a kindness campaign. It's really remarkable, and we've had stories of people being kind to each other in car parks and all sorts of things. It's really lovely to hear. it leads nicely into just a couple of words that I wanted to say, because I've been thinking a lot about what you said about Simon Stevens' remarks and how we begin to pick ourselves and go forward. And that I've been thinking of the sort of concept of healing and learning, because there's been so many things happen to us in this period, and we've learned so much, and we can do so many things in different ways. And I think kindness, healing and learning sounds lovely. So thank you for that. I just wanted to update you about the board-to-board buddying scheme with CFT. This came up in one of our board-to-board informal meetings, an idea that we would have, we would buddy up with somebody from CFT, and Julie Stone and I got our heads together and made some decisions, because we thought we'll never get on with it if we don't. So if you haven't already, everybody will be receiving an email suggesting whom we've buddied you up with. I was keen that we did it, because I was one of the girls that never got picked for the netball team, and you were left standing on the field feeling miserable. So we've just gone ahead and done it. What we're suggesting in the first instance is you buddy for a 3-month first tranche, and we can review after a month, and I'm sure we'll do a lot of learning. So you can blame Julie Stone if you don't like your partner. It's nothing to do with me. I just sat there.
Mary, can I just mention something Tom's reminded me in the chat?
Yep.
So, things happen and then we move on, but we haven't told everybody that the outcome of the review of the Department of Health and Social Care, and subsequent discussion by our regional director team, is that the planned work on integration between RCHT and CFT is recommended to continue, that we have a checkpoint before we proceed into the full business case, but that the strategic case is well made. The business, i.e. what's going to be good about it for people in Cornwall, has been well made, and we now need to focus on the models of care so that people in Cornwall get what they need from services, and that integration of bringing people together is what we're planning for the future.
Thank you, Kate. That was a helpful reminder, and much to be celebrated as well. And thanks to people who've got a lot of hard work and know there's a lot more hard work to come. Which is a nice segue into my next duty, both sad and glad, I guess, and that is, Margaret, formally to mark your leaving our board as a non-executive director, in order to take up a position as acting chair of Cornwall Partnership Foundation Trust. Now, Margaret has been a member of our board as well as a member of CFT board for some considerable time. And we are really sad to see you go, Margaret, but we're also thrilled that you go on as a partner and can work with us. I see that Margaret's put a note in the chat about giving her board a little bit of a talk about charity and charity beginning at home. So we're in line again, Margaret. Margaret, you joined us on the 1st of November 2016, and I know how tirelessly you have worked for the RCHT. You've been a really excellent chair of the Quality Assurance Committee, where I know you, together with Kim and others, have really worked to bring that committee into a well-functioning committee. And you were also a good chair of our Audit and Risk Committee. You've always been the best champion for our patients, and you have supported me in role of vice chair with integrity and with passion. We make a good pair, Margaret, because we come from opposite ends of the spectrum, but we come with the same value base, and I think that's a great pairing. So it'd be very good to work with you in your role as acting chair at CFT. I honestly believe your commitment to the people of Cornwall and to the staff of the Trust is second to none, and it is undeniable that we'll miss you. And I really have always appreciated the little nudges you occasionally give me when I'm not talking a lot of sense, and you help me to get back on track. So I'm really pleased that I'm hoping during today you may be receiving a small gift through your door and a card that people have signed. And I don't want to embarrass you, but I do want to give you a chance. If there's anything you'd like to say, you're very welcome.
Had to find the unmute. I was simultaneously earlier on the mental health chairs weekly call and this, and it was like quite strange. And the topic of conversation was Ned's on 2 boards. So I was able to contribute to that as I was watching this board meeting and contributing to that. So it's actually, I do want to remind those of you that weren't there at the time, Mari was talking, we were down at Penzance at West Cornwall Hospital, and Mari was talking and talking and talking, and I could understand each word she was saying, but I didn't know what she was talking about. So I finally just put my hand up and said, Mari, I'm sorry, but I haven't got a clue what you're talking about. And that was pretty much the start of a very good relationship, because we were able to learn to speak each other's languages, and she can say it softly and I get to the point. So blunt. I miss you guys terribly already, but it's not for long, because with all of us working towards what we know is going to happen sooner rather than later, our integration, I think we'll all be back as one happy family very soon. So I may not be sitting around the private board, and I might always be here for the full public board, but you know that I'm always the biggest advocate for RCHT that there is in the county, and I will remain that way. I like the journey we're on. I think it's the right reason. We're doing it for the people of Cornwall. We're not doing it for anybody's ego. We're not doing it for any aggrandizement of any organization. We're doing it because we think it's the right thing for people. And as I intend to grow old and die in this county, I want to make sure that it's fit, fit for purpose. So there you go. Nothing like a little bit of self-interest to get us all motivated. So as John Maynard, or excuse me, Adam Smith told us, it's not by the benevolence of the butcher or the baker that we get our meat and bread, but enlightened self-interest. So there we are.
Well
Anyway,
said, Margaret.
I'm off.
Well said.
To do other things, but I won't be far away. So lots of love to all of you, and I can still see all of you on one way or the other, especially when we can get back out stomping around our territory. Thank you.
Thank you so much, Margaret. Thank you very much, and we will go on working with you. And the point about the integration is for the people of Cornwall absolutely demonstrates your passion and where you are, and I agree with you entirely. So thank you, and au revoir, not adieu, I think. And I guess perhaps to round that up, for people's knowledge and interest, we have placed an advertisement to recruit to the vacancy that Margaret leaves. And we really look forward to applications from people with senior clinical experience. And we particularly welcome people from all the minority groups. You know, anybody listening today, please pass the word around. It's a hard job to do, but it's an amazingly rewarding job to do. And we really want to encourage citizens of Cornwall to step forward. So thank you for all of that. That brings us to item 6, which is our patient story. And we welcome Hayley Townsend and Cheyenne Tristram to our meeting. I've got terrible feedback, I'm sorry, but if I could perhaps hand over to you, Kim, our Director of Nursing, Midwifery and AHP, to introduce the item. Thank you, Kim.
Yes, sure. So for the public and members of the board, can I just introduce Hayley Townsend, as Maury has just said, and Cheyenne. So Hayley is one of our ward leaders on Karen's award, and Cheyenne is one of the Meaningful Activities coordinator. And it's with great delight I welcome you both today. And just before I hand over for your presentation, I think it's really, and you'll see, demonstrable the absolute positive impact, and especially later when we talk about falls, this is one of them, I think, the most groundbreaking ideas and absolute roles that we need to take forward throughout the trust, and of course, being a joint director of nursing, midwifery and AHPs, we are rolling out in CFT community hospitals as well. So without further ado, Hayley and Cheyenne, welcome, and I'm delighted to hear your presentation today.
I think you're on mute.
Okay, can you hear me now?
Yeah.
Yeah,
We can.
okay. Yeah, so I'm Hayley, I'm the ward sister on Carenza, and with me I have Cheyenne. Okay, next slide. I can't see all of the slide, I don't know why. I can only see half of the slide.
Frame, that'll make it work.
Okay, yeah, that's better, thank you. So, no, it's gone back to small again. Can you make it smaller so we can see the whole thing?
We can't control it, unfortunately. It'll be at your end, so you just have to right click on it again and do fit to frame.
Okay, yeah, that's it, got it. Okay, so the aim of the Meaningful Activities project was to have reduce patients' length of stay, reduction in incidents, and obviously job satisfaction. So we did this by asking for patient and carers feedback, and we also did a staff survey to gain staff's feedback on how they felt the meaningful activities were a benefit to the wards. So we wanted better use of resources, so our staff capacity, continuity of care and support, and integrated working with CFT in Taunton. So we did this by appointing 5 meaningful activities coordinators. They were all appointed, they all had special strengths. They were all very different in the skills that they brought to the wards. Some were very musical, some were arty, but yeah, all brought very positive skills to the job role. So we engaged with CFT in Taunton. They already had meaningful activities coordinators that were very well established within their hospitals, so we learned a lot from going there and shadowing them for the day. We provided the meaningful activities with resources. We empowered the individuals, and they presented at the enhanced care workshops to encourage other staff to attend. I know Cheyenne did a presentation for the enhanced care workshop recently, and we took a chance to do something different. Next slide. So the role did have its challenges. I know Cheyenne's going to talk about this because it was a very new role. So Cheyenne, I'll let you talk about this.
Yeah. So from my personal experience as a MAC team member, bearing in mind I started right at the very beginning when there was only 2 of us. I think the main challenges we faced was the difference in approach. So obviously all of the clinical staffing are very task orientated, and as a MAC we aren't at all. There's no task orientation at all. We just go with the flow with the patients, very dynamic, changing, and I think that was, I think people couldn't figure us out to begin with. And there's that relationship with the healthcares who were on a one-to-one with enhanced care. They sort of wanted to stay with those patients so that they could like have an easier shift, and we would take away those patients and get them up doing stuff. And I think people were quite nervous that we were getting their more aggressive patients up and doing stuff. But now obviously they've seen the benefit, and we have too. So yeah, the other main challenge I would say is trying to integrate ourselves across the 3 wards during the pandemic, because at times we can't really do activities. So I think the staff can sometimes become slightly confused on the wards that we're not as well known on. Yeah, I think that's it.
You're on mute.
So we can, evidence that there were financial savings for 3 consecutive months. There was a reduction in the need for additional staffing, because obviously we didn't need our own health care to provide the enhanced care, because the meaningful activities We're engaging patients in activities, so we didn't need extra health cares to do that. There was definitely a reduction in incidents, falls, violence and aggression. So I did a piece of work around this, particularly around the falls. So prior to the meaningful activities starting in their role, we had 35 falls, which were through the DATEC system. And in the first 6 months of the MAC team starting, it went down to 20, so a significant reduction in the falls. So that meant it was a 43% reduction in falls on the ward, which was massive for us. It made such a difference. And also, you know, for our patients, they had an overall better experience of being in hospital. You know, we know that patients that come to Carenza, most of them have a dementia. So if they come in with a delirium on top of the dementia, they're very frightened, disorientated, and they need that skilled approach to make them feel safe and to make their recovery quicker. And that showed massively in the engagement from the meaningful activities coordinators. Okay, next slide. So the staff survey, which we did it via the Survey Monkey. We did it in paper format for both Tintagel and Carenza, and it was open for a 4-week period. So 42 survey responses were received. So out of those responses, 40 out of 42 understood what the role of the MAC team were. 38 out of 42 felt that there had been environmental changes in the areas where the MAC service is provided. 38 out of 42 felt that the MAC staff helped improve patients' health and well-being during their stay in hospital, and 41 out of 42 felt that the MAC job role is beneficial to the trust. Next slide. So this was one of the patient registers' feedback, which was lovely to have. So they said that when she began to improve, the wonderful activity team were brilliant in helping her engage with day-to-day life each day, a much better option than leaving patients to sit or lie in bed. When she moved to a community hospital to continue her care, they fully informed me of when, where and what procedures were in place, which was lovely feedback to have, because, you know, that's the type of what our whole aim is for, to make it a better patient experience. Next slide. Okay, so Cheyenne's going to talk about the materials that they've used.
Okay, so the materials that are on the screen are materials that we use regularly. It's sort of like our staple thing. So it's card, coloured pens and pencils, glue sticks, PVA, tissue paper, paints and brushes, whiteboards and clay. But obviously, as individuals in the MAC team, we all bring different skills. So for the musical MACs, they probably won't use these things as much, or like as a team we've been able to build up different things. So I have made quite a lot of proverb cards, so it's like a matching game, and reminiscing cards for patients who struggle to communicate and need some additional help. We can try and get clues from these pictures. So say I show them pictures of various different things and they begin to smile when they see a sewing box. So then I might go to the haberdashery section and bring out another one and go from that. So that way we've been able to find out more things. And then at that point is when we will start using the card and paints and pens and etc. You're muted again, Hayley.
Okay, next slide. So our next steps is to share our learning with other groups and to share the good work that the MAC team are doing. To review our budget, we'd like to create a MAC lead, which will be amazing to have, and continue to build our relationships of collaborative working with CFT in Taunton, because I think, you know, we can still learn a lot from each other within the roles. Plan ahead with our activities and resources for reusing, which we've already got. Start group sessions, which I think we've already done a bit of group sessions within the MAC team, and support the MAC team in their venture of Singing for the Brain. So Singing for the Brain is a service that was provided by the Alzheimer's Society, which uses singing to bring people together in a friendly and stimulating environment. So it will be amazing to do that on Carenza, and continue to share our successes and good news stories. Next slide. And just a last quote, it's the simple things that can have the biggest impact, and we've certainly found that with the meaningful activities coordinators within their job role on the wards. They've been amazing.
Goodness me, both of you. What a superb presentation, and what exciting work you've told us about today. Thank you so much. I'm sure there'll be lots of people wanting to speak. Kim, before I say any more, did you want to say anything to round up?
Yeah, can I just thank Hayley and Cheyenne? I know how intimidating it can be to be asked to come to board and share a story. And even though I know you were both slightly nervous, absolutely well done. And I think this absolutely showcases the braveness you had to step out and try a different role, and the incredible benefits it's had for patient experience and our staff health and well-being and job satisfaction. And it's something now, especially during COVID, how we roll that success out, which will be key critical. So we'll definitely be looking for you both to champion the cause. So thank you very much.
Thank you, Kim. I can see questions and excitement coming in on the chat, and I'll bring you in. I just, well, I think I'll save my remarks to the end. Richard, you've got a first question, then Alistair. Richard first, Richard Stevenson.
Okay. Thank you very much. What an excellent presentation, and I can see the reward that you get from it, as well as the reward that our patients are getting. So thank you for all you're doing. I guess my question is how the multidisciplinary team might wrap around this. I'm particularly struck with occupational therapy being around meaningful activities and meaningful occupations, but I'm also, I suppose for you, Cheyenne, the support you have from that team to help you really think about the maximum therapeutic benefit of the meaningful activities as well as the well-being activity. So just interested how that whole team wraps around this to enhance the skill base that you've got.
Yeah, so on some wards it's working better than others. So I'd say on Carenza, I think we've established ourselves very, very well. So everybody has their handover, and then when they finished, we usually have a catch up with Hayley, who will tell us which patients we should focus on. When I see the occupational therapy come out, I generally go up and ask them also if they have anybody that they would like me to speak to, or as well, Maria, the discharge lady, she comes over and asks how the patients have been communicating with others, if they're thinking about going to a care home. We've had, it's lots of different things. We've been able to bring up multiple safeguardings that wouldn't have probably been noticed when relatives were coming in. Yeah, continuing work that physios are doing, encouraging people to drink, things like that. I find the patients are more willing to accept the advice when they're around other patients.
Yeah. That's brilliant, thank you, really helpful. Thank you.
Thank you very much. I've got Alistair, Ruth and Kate, and that may be the limit of the time we've got. So Alistair, Ruth and then Kate.
Hi, Hayley and Sharon. Thank you very much. It was a really good presentation, and I speak from experience of having had a mother who was very agitated with dementia just before her death, and I know that meaningful activities like singing were absolutely key to her having a good experience. So I really value this. I was interested in your patient survey. You talked about environmental changes that had happened that people had noticed, and I wondered what those might be and whether that was something that you as Max had suggested in terms of ways of changing the environment, or whether that was something that didn't come out of this initiative.
So I think there's two ways. So we have changed the environment in terms of obviously like the day area on Carenza or Tintagel or Tormex. We've tried to make it a bit more inviting and a little less clinical. Or, for example, if patients are really into art, or if like the day we had bunting everywhere, we do different things. There was a patient fairly recently, it's during the first lockdown actually, she was really, really agitated. She said all she wanted to do was go to the pub. So we changed the day area into a pub. We do things like that. So we do change the environment physically, but some of the healthcares have also mentioned that it's more friendly. From us being there and in the middle and talking to everyone, they said that the environment has changed in that way as well.
How fantastic. That just sounds amazing. Well done. Thank you.
You're next, Ruth, were you?
Okay, thank you, and thank you for a really fantastic presentation. And I have heard about the work that the team's done from lots of places, and it's really, really important how we keep people active, interested, put some joy into their day in order to decrease their dependence on the system. I think mine's a bit of a follow-up from the question that Richard asked, but also a suggestion. We do have OTs, but we also have art, drama and music therapists in Cornwall. And I'm wondering about your own development as a team, thinking about your own CPD going forwards and the development of the service, whether linking in with those people might help with that aspect of the service going forward. So your own development.
Yeah, I think so. I think more skill sharing the better, I think, because we can, as Max, we're all different, but we can only wear so many hats. Like we already try and get in other people. If we know that there's a nurse who can play the guitar, we will try and nab her for a period of time, or like the chaplaincy team, or yeah, we'd be really excited for that. Yeah.
Yes, from a award point of view, like Cheyenne says, the more skill mix that we can have, the better for all the wards.
I think you're on mute, Mary. So if I come in with my last point, is that okay? Yeah, lovely. So I feel really strongly, particularly around elderly people with dementia, because I, like Alistair, share a story of having a mother who had vascular dementia for many years. And one of the things we talk about a lot is when we integrate with a CFT, the models of care that we'll have in place to look after people, and it's all going to be about them. It's going to be about me when I'm old and what I want to do and what I don't want to do. I love the idea that you turned the ward into a pub, because my mum for 10 years went to the pub every day with her carer and had a prawn sandwich and a glass of wine, because that's what she wanted to do. Now, staff services never provide that sort of model of care, but if we were going to be really, really ambitious for what care looks like in our integrated service, then having mind, body and soul workers, which is what we've talked about, which is what I think you are. We might call you, meaningful activity coordinators, but you're bothered about all of me. So how do we get all of our people to be mind, body and soul workers, and some of them to focus on one bit of it more than others? So I think we've got an evidence base here that we should be using to test and develop our new models of care around. Because I tell you, when I'm 85 living on the Lizard, you will not get me out of my house for anything. All going to have to come to me. And I want to manage my own risk, thanks. Don't go telling me I'm
Except the pub.
Yeah, because I'm still 19. I will always be 19. So I really thank you. You've given an evidence base to what was an idea, and I think we need to build on it. It's amazing. Thank you.
Thank you, Kate, for saying that. You absolutely encapsulate. I think the fact that we've got an evidence base, I think to hear such a positive thing, and then for the more financially minded amongst us to hear there is actually also a financial benefit in it is stunning. And I'd be saying, can we have that money back, please, to do a bit more over here? But it's been a really lovely presentation. You did it beautifully. And I think as well as that reduction in falls and all of the good things of the mind, body and soul that Kate refers to, helping people to feel safe when they're frightened, helping them to feel included and helping them to feel as if they matter, they can still contribute. It comes across in both you and Hayley's presentation. So I think on behalf of the whole board, and I guess lots of members of the public watching us, I want to thank you very warmly for wonderful, wonderful work, and keep it up and do it more. Thank you very much.
Thank you.
Thank you. Thanks.
You are very welcome to stay with us for the rest of the meeting, but I'm sure you've got more exciting things to do.
We have. Thank you, though. Thanks.
Thanks very much.
Bye.
Never works, does it, Kate? I always try to get people to stay.
Always.
Okay, thank you for that, Kim. That is really heartwarming, really helpful. Which then brings us on to item 7. I want to invite you, Robin, as Acting Director of Operations, to introduce the report, which you're going to present through PowerPoint slides. So it will help everybody if we turn our cameras off so that we can see the slides. I think, Robin, forgive us if it feels a little bit challenging at times. I think we really do want to ask the questions that are going to demonstrate the robustness of what you're presenting to us. So you have, I hope, a good amount of time. I think we've allowed 25 minutes for this. And so we will, I think the best thing for us to do is if people have got questions, will you indicate with an X? And then we may need to take some questions during your presentation, Robin, but let's see how it goes.
Thank you, Mary. I think it worked quite well last time. I rushed through the presentation a bit to give us more time for questions. So I shall do the same again, and if people feel I've rushed a slide, we can always go back to it in the questions section. So next slide, please, Pete. So this is, we do this each time, the overview of where we are from a COVID perspective. So the presentation is made up of three sections: what's happening in COVID now, what the impact is on RCHT, and then where we are in terms of a recovery. We always have our eye set on the future as well as dealing with the here and now. So I will talk through briefly where we are at the current position, our visiting restrictions, the vaccine update, a reminder of our approach to that recovery. Then I've got a slide on risks and then the challenges that we're currently facing. Next slide, please, Pete. So very quickly, if you remember this slide from last time, it's now we're now moving into the slightly lighter shades. So we are starting to now see across the county of Cornwall a reduction in community rates of infection. Generally speaking, from our experience, we tend to see from a hospital perspective, the admissions to us lags a reduction in community infections by about 2 weeks. So this reduction here doesn't result in an immediate reduction in demand for our services, which is why we're very much aligned to those national messages around please continue to follow the rules from a lockdown perspective. We know it's hard, but just because community rates are dropping, the hospital is still under pressure from COVID, so we are very much still busy. Next slide, please, Pete. And then to emphasise that in our last meeting, we had 56 patients total in the hospital with a positive diagnosis of COVID. And as at this morning, we have 100 patients. And for the last week, really, we have been running at the high 90s, very low 100s. So our teams are really busy with a high number of COVID patients. We have the capacity to manage that. We have strong plans that enable us to create sufficient, we call them red wards, our COVID wards, sufficient dedicated wards for our COVID patients. At the moment, we have got 13 patients in our ITU department and 1 patient in our HDU, high dependency unit, sorry, an acronym there. Again, just like with the ward plans, we have strong, robust plans for how we make sure that we continue to increase our critical care capacity as the demand needs it. And I spoke last board around how we come together with all of our clinical leaders to it's not formulate those plans because they're already there, but agree how we move into each of the next steps. So all of our plans work on the clinical leaders coming together with me, with Alistair, with Kim to talk through. We know this is the predefined next step. How do we enact that next step? What's the data telling us? So we're always, I phrase it as we always stay in front of the virus. So we always know what's going to happen next should we need to use that space. However, sadly, since we last met, we've now moved to 161 patients who have died with a diagnosis of COVID, and that's an increase of 65 from our last meeting. And it's important that I pause at this point because I want to show that we don't see this as a number, we see this as 161 individuals, and we take this very personally for every patient that has sadly passed away with COVID. Next slide, please, Pete. Thank you. So as I mentioned previously, we have our 4-phase plans, and they are they've all been signed off through our clinical leaders. They've all been through a check and challenge session. All of those plans were refreshed from our learning from the first wave of COVID, and that works from a number of triggers that identify to us when we need to move into our next phasing of our plans. The main driver for that is the demand on our ITU services. So as we saw the numbers of patients on ITU increase, we enacted other elements of our predefined plans. But each time we enact those elements, we involve our clinical directors because then they give us that safe sense check that the data is definitely telling us this, we're definitely in this position, and this is still the right thing for us to do as per our documented plans. We maintain keeping our staff readied for the redeployment process to support frontline services. We have got a huge list of individuals that have stepped up, stepped out, gone way above and beyond to make sure that we continue to deliver the high care that we aspire to for our patients. And every day I'm absolutely astounded by the number of people that are coming into work expecting to do one thing and changing to do something else because that's what our patients need of them. And that is very much part of our structure of how we make sure that people who need enhanced support get that enhanced support. We've also got a number of staff being trained up to be able to take on more roles for us so that should we see further increases, we're ready and able to manage that. There is, however, a significant risk to our recovery on the waiting lists. I've talked last time about our trajectory, and I've got a specific plan slide on that. But as we said last time, our cancer and our high urgent cases remain our priority. Kate's mentioned in her brief earlier that we have cancelled some cancer patients, but they are in single digits, and every single time we cancel a patient, cancer or otherwise, that is done with a full clinical review. I have to take this opportunity to have huge gratitude to my teams in surgery who have worked tirelessly to move their resources around so those cancellations have absolutely been minimised, and without their total commitment we would have seen many more cancellations. So I and I think we all owe them a huge gratitude of thanks. Next slide, please, Pete. So this is an update on our COVID visiting restrictions. For ease, I've highlighted the changes from the last meeting in green, and that is that the visiting is restricted to all but those who are at end of life, maternity, paediatrics, and clinical best interests visits. That's the addition that we've added. And for paediatrics and maternity, we were allowing people to attend at 12-week scans and 20-week scans already, but we've also increased the visiting availability where it is anticipated that people may be given bad news in their appointment slot, so that we can make sure that our patients are appropriately supported in these very difficult times. Next slide, please, Pete. So one of our success stories is the continuing rollout of the vaccination. We spoke last time about how the teams have got the Tower Block operating and the Health and Wellbeing Innovation Centre. Our GPs are flat out vaccinating as well. But now I'm pleased to report that, and you may have seen this in the news, that Stithians Showground and up at Wadebridge, we now have 2 mass vaccination sites up and running in Cornwall. So we will see the number of vaccinated patients further increasing. Just a reminder that vaccination started in RCHT on the 9th of December, and we are completely aligned with the government instructions as to the priority groups and the sequencing of timing. And all of this is well coordinated across the whole of Cornwall and Yards of Scilly to make sure that all of our patients who when they are entitled to the vaccine, receive that vaccine. Next slide, please. So a very quick reminder of our elective recovery approach, which is our sole purpose is to make sure that we minimise harm through the COVID pandemic. And that's why I mentioned earlier that any patient cancellation, any clinics we're standing down, that is all done with our clinical leaders. This is not an administration function that we do here. We drive the need to minimise harm by using our clinicians to advise us where we can safely postpone activity. We have the harm review process that I've mentioned before that then gives us a catch-all at the end to assure ourselves that we are booking patients at most risk of harm into appointment slots so that we minimise that impact. We do have a number of rate limiting factors that we've spoken about before, the need to maintain social distancing. Our PPE requirements we list as a rate limiting factor. Although we have no supply issues, we're very conscious of the need to make sure that we're keeping all of our staff well supplied with PPE, and that can cause some of our processes to take longer than they used to because of the time it takes our staff to put that PPE on and take it off safely after they've been with a patient. We have to remain a flexible approach in our responsiveness to the changes in COVID-19 presentations, and that again is why it's so useful to me and so powerful for all of us that our clinical directors all come together as the presentations change so that we can do that cross-check of our existing plans. We thought this was going to happen, it's not quite happened as we thought. How do we all assure ourselves that the steps we're taking are the right steps to take? Next slide, please. This is our December data of our recovery against the phase 3 recovery standards, which broadly speaking we're achieving. The reason it's December data is we haven't yet completed the validation of the January position, but I will give a forewarning that our January position on these phase 3 recovery targets will drop due to the fact that we have cancelled our routine activity in support of the COVID pressures. Next slide, please. So this is a trajectory chart that we've seen many times now. Red line up until end of December was matching brilliantly with the planned green line. I haven't updated the trajectory at the moment. You can see that in the January phase that we've just started to see our RTT performance, referral to treatment performance, coming away from our planned recovery programme, and that is specifically linked to the cancellation of activity. Because we are in that place right now of evaluating when we believe our elective activity switch on point will occur, we haven't redone our trajectory at this time. As soon as we're in a place where we can see that the numbers are moving as per the scenarios that have been modelled by our informatics team, we will then update this trajectory to show how we will then implement our recovery plans to get back on track with our referral to treatment performance. Next slide, please. For total transparency, I want to be able to show to you our longest waiting patients from January. So on the left-hand side of this slide, you can see the number of patients that have waited more than 52 weeks. In January, that has increased to 728 from a position of 519 in December. If you will remember the previous updates I've given, we always achieved better than we forecasted for our 52-week wait breaches because of the recovery actions that our teams are driving. Unfortunately, with our routine elective work stood down at this time, our ability to reduce those 52-week waiters has reduced. So this number sadly will continue to increase at this time, but be assured we already have the plans in place that when the COVID numbers reduce, we will be able to switch on those pre-delivered plans, so we know they work, we've done them before, and we will go back into that place of making sure that those 52-week waits further reduce. On the right hand side, I've shown the other marker that we report nationally, which is the number of patients that have waited 78 weeks or more, and that currently has increased to 21. It's important that I re-emphasise these long waiting patients do go through our predefined harm review process. So whilst none of us like to see these numbers on this slide, the really important piece is these patients have gone through our harm review process, and if there were indications of risk of harm, we have mechanisms to be able to ensure that we can bring these people in for their treatments. Next slide, please. So this is our diagnostics performance. So January, our overall position is 84%. We're just finalising the validation because month end is just finished. That number won't change significantly. Our December performance was 89%. The areas that have reduced significantly are urodynamics and our audiology diagnostic procedures. Every week we have a referral to treatment performance review meeting with all of our care groups. That's happening right now as I'm talking to you, and one of their key focuses is to go through the recovery action plans for those two specialties, taking exactly the same methodology that we used for endoscopy. And as you would have seen previously, that endoscopy recovery plan delivered month on month the recovery plans that we committed to. Next slide, please. So our cancer 2-week wait and 2-week wait performance. Our number of patients seen within 2 weeks, the performance dropped to 82%, and that is, as we predicted, as a direct result of the still above our normal referral rate for breast patients and the capacity issues that we've previously described here. So that was expected. As I've said previously, we are, however, continuing to treat our breast patients within 62 days. So although our diagnosis is delayed, we are still delivering the treatments in time for those patients that have got confirmed cancer. Overall, our 62-day performance reduced slightly to 89.8% in January, again in December, sorry, against a performance of 91% in November. We have a micromanagement mechanism in place, and our teams are making sure that they are tracking every single cancer patient. This remains under pressure for us due to the high number of COVID patients that we're working with, but this is our absolute priority, that we continue to create capacity for our COVID patients and our cancer patients. Next slide, please. So the update of minimising risks. The main risk to draw your attention to is our ability to manage electives, because we've stood down the elective activity, as previously mentioned, and as we're seeing more and more COVID patients, our ability to flex is becoming slightly more challenged, but it's not an area of particular concern for me at the moment because we have really strong processes in place. We are very, very focused on all of the actions that we need to do to make sure that we minimise any risk of transmission of the virus within the hospital, which is known as nosocomial spread. On the next slide, please, Pete. Thank you. So the one challenge I'll just bring your attention to is that because of our current high number of infections and hospitalisations, our recovery plan is now off of plan because we've had to stand that activity down. And the last slide is just a summary reminder of our action plans. So I've done that as fast as I possibly can to leave the floor open to questions. I saw lots of chat coming in as I was talking.
Thank you very much, Robin. You've done really well. We've got about 6 minutes for questions, but we'll take more if we need to. I have a couple of questions, but perhaps let Sarah Newton have the first question. If you can indicate in the chat if you have a question. Kim, you'll be second. So it's Sarah and then Kim.
Thank you very much for an excellent presentation and taking us through that information so speedily but so thoroughly. Our recovery plans did work well after the first wave of the pandemic, and I'm just wondering to what extent has the very necessary work that we're planning to do for our staff on rest and restitution after the current phase of the pandemic been taken into consideration in future plans for the recovery plans for our patients as and when we can do that?
Really good question, Sarah. So what we're doing with our care groups is they're taking the plans that they used in the summer that worked. They are now refreshing them exactly the same as we did for our COVID plans. We're now saying, given what we now know, how are we going to re-implement these plans to deliver as we did last time? And in that is the element of making sure that if we need to be giving our staff some rest time, that we've incorporated that. So that will enable, because of the way our modelling works, we will be able to take the plans from in the summer, factor, if we need to, a reduction in capacity if we are providing that rest and recuperation time, and then our trajectories will match that. And as you've seen before, once we've set our trajectories, we deliver what we say we'll deliver, and then we will keep bringing back to you that this is our trajectory, this is what we're delivering. And just like last time, as we bring on new activities, we will come back to you and show you that we've improved the trajectory, and then you'll see our delivery line matching that improved trajectory line as well.
Thank you.
Thank you, Robin. Kim, thank you for your note. I realise I made a mistake there. Kate, you wanted to come in on this one.
Yeah, specifically on this one actually. So nationally, they're setting up 2 work groups to support NHS-INE around looking at prioritisation of elective recovery, i.e. not everything needs to be done at the same time, and how we support our workforce, acknowledging that they've worked their socks off in first, second and third waves, so asking them to work their socks off straight away for recovery probably means we'll destroy people. So the things that I think we'll be focusing on here is around appraisals, mandatory training, long COVID and health and wellbeing, so that we use the things that are important to regroup our people, making sure they take their annual leave, making sure that we can, we've got teams that still function, but we allow some downtime. At the same time as that, I think nationally we're going to be giving some advice on prioritisation, and I'm really hoping we start to use international evidence around advanced enhanced supportive care and shared decision making, because just because we can do something doesn't mean to say it's the right thing to do. And we've probably got waiting lists of people that once you're on the I don't know, what do we do to people? We do interventions. Once you're on the intervention train, it's really hard to get off it. So I think we will be doing some work nationally that puts the person at the centre of it, not the RTT target.
Thank you, Kate. That's exactly how we should be going about it. Could I just remind the board that there was a question from Paul about take up at the mass vaccination centres. He asked what it was like, and Kate responded to say full, definite full take up. So, Paul, did you want to say any more on that, or is that done?
There's been various chatter on social media more than anything else that there have been slots available, and I was asked a question about it yesterday, and I spoke to Ian directly on some of that, Ian Davidson, who's coordinating all of this. But it was just confirmation to the board more than anything else, Robin, if you could, in respect of the take up. And I think Kate's answered it, but if you could.
So our team monitor what they call wasted vaccines, and our wastage is very low. It's under what nationally would be expected to happen. And then we have a really keen team that they drive that wastage down further, so they deliberately overbook slots so that if they have patients not turn up, then they've effectively already created that buffer. So and if they have everybody turn up who they've overbooked, then as our Director of Pharmacy says, they'll just unfreeze some more vaccine to make sure that everybody gets that vaccine. So anybody who's listening, if you're given an appointment slot, please come. We can absolutely manage you turning up and we'll get your vaccine. But we make sure that we book more people than we're planning to for the day, so that any non-attendances are effectively scooped up in that regard.
I think it's important though, because there was an awful lot of stuff going on Twitter around wastage. So I think I was trying to look for my my report from last night, because every day we get a report that tells us how many vaccines have been wasted for time and for human error, and we're so low. We're ones and twos, and within the hospitals we have a ticker tape that says spare slots going over at the Health and Wellbeing Centre. Come over if you want to have a vaccine. The only thing is, no second vaccines unless you're in a clinically exceptional group, and there are so few of those. So we are using every ounce of the vaccine we get.
That raises a question, Kate, very briefly, in terms of hospital take-up of vaccine, in terms of our staff. Do you know the answer, Robin?
I don't know the exact. Sorry, I don't know the exact percentage, but we have seen really high numbers of our frontline workers, as per the guidance, taking up the vaccine. And when you walk past the vaccination hub for the frontline workers, they're always socially distanced, well queued, ploughing through those vaccinations. So we're definitely well on track, but off the top of my head, I couldn't quote.
No, that's fine. That's fine. Sorry, I threw that.
Thank you, Paul. Thanks. I've got Adam and Tom, and then we need to stop. So Adam, would you ask your question, and then Tom, would you ask yours straight after, and then Robin, if you could answer both, because we're needing to be careful about time. Thank you. Rob.
Okay, thank you, Robin, for an excellent presentation. My question's about the visiting rules, and if you could say a bit more, please, about how we make sure patients, families, all relevant parties know what the rules are, and in particular, where there's going to be a change in the rules, how do we make sure everybody's notified promptly?
Thanks, Adam. And then if Tom could come in, and then you wind up. Thank you.
Thanks. Really good presentation, Robin. Actually, the question's more for Alistair, actually, and it relates to the harm review aspect that Robin covered. So Robin, I think, gave really good assurance as to what our prospective harm review process is when we look to prioritise patients on the basis of potential harm. I guess it was more about the retrospective process. So when a patient does eventually come in for whatever procedure they're in for, and we identify that there's the potential that that delay has caused actual harm, so it's been realised at that point, what process we then put in place with that patient.
Thanks, Tom. So Robin, if you could do Adam and then Alistair, Tom, and then we'll stop.
So yeah, Adam, we make sure that we communicate with our patients in letter. So when you get the appointment letter, you get the visiting instructions as part of that letter. If we change the visiting instructions, we publicise that on our website and also on our social media platforms. We make sure that all our booking teams know the changes. So when they telephone a patient to make an appointment, they have that conversation with the patients. And then as the very final checkpoint is when people turn up, our security teams are well briefed so that they can explain the visiting changes if they've happened to the patients. One of the key parts for us is we've been very stable with our visiting restrictions as an organisation, which I believe makes it much easier for people to understand what we're doing and why we're doing it.
Lovely, thanks, Robin.
And then, sorry, to answer Tom's question about retrospective harm reviews. So we have a process around retrospective harm reviews, which is facilitated by our business intelligence team and our radar reports. So our radar reports are pulled off regularly by the care group leads, and any patients who are admitted, who are on any of our waiting lists, either for outpatients or for procedures, who've been admitted to hospital, will be flagged, and those patients then get a harm review performed. Those harm reviews are reviewed by myself and the harm review panel, and any patients who have moderate or severe harm identified by this process would have a duty of candour performed, as in line with our statutory requirements. I have to say that our retrospective harm reviews over the course of the the 2 waves, 3 waves of the pandemic have so far demonstrated very little in the way of moderate or severe harms. We have seen some low-level harms, but moderate and severe has been very small.
Thank you very much, Alistair. Thank you, Robin, and all of your teams. That's been a really good presentation. I do want to endorse what you said about how grateful we are to staff, and I think that the way staff are stepping up is remarkable. I like your phrase, stay ahead of the virus, and I note the answers to questions about staff care and development, also the waiting list. So thank you, Robin, and we will wish you well as you go on. You're leading this really brilliantly. Thank you very much.
Thank you very much.
I was going to say onto item 8, we're on time. We're now not on time, just for us all to be mindful, but that's okay. So we're heading for a 15-minute break at 11:25 if we can manage this. So let's see what we can do without cutting corners. So key points only from presenters. And just before asking you, Kate, to pick this item up, I just want to note that regrettably, the front sheet on the IPR is not quite accurate. So apologies for that. This is the board IPR and the data is not August data. It is the most recent data that we have available to us. So apologise for that. And over to you, Kate, to take us through the IPR, please.
Thank you, Mary. So we'll do it in the way we've done for the last few boards. I'll just do a brief summary and then I'll ask individual directors to come in and to speak. I'm not going to talk about COVID or our performance because I think Robin has talked us through that really fully. I would just like to pick up some issues that we're still worried about and trying to put right around ambulance waiting. So Robin has only yesterday agreed another approach with South West Ambulance Service about how we can work better together to stop ambulances at our front door. And of course that then leads into the 12-hour trolley waits that none of us want to have in terms of our paid people waiting to get into the right part of the hospital. I'd like to draw your attention to the fact of the amazing news around our stroke service. So you remember 3 years ago we were rated, I think, as C for our stroke service. We didn't know why. We've done a lot of work over the last 3 years and we're now got an A rating for the first time for the care of stroke patients. And that's been led by Katja, I can't Katja's surname. That team led by Katja has done. So that again,
ADIE.
Yeah, Katja AD. They've done such an amazing job, both inside the hospital and in the community. We've got an integrated service. I'd also like to celebrate, whilst touching wood, that we've had 111 we've had 0 never events for 111 days. And as part of our CQC action plan response, 41% of our staff have already completed the World Health Organization training for theatres, and that's 892 people. We intend to have 100% of all eligible staff completed the training by the 31st of March. It's sad to see that our falls are still increasing, and it's something that both Kim and I are worried about. Probably a sign of pressure in our services, but perhaps also a sign of us having people in our hospitals who perhaps should be somewhere else in a less, for them, dangerous environment. Again, about the RTC, I won't mention. The outpatient transformation programme is still, this is on page 3, it's still going great guns. And remember we had that nomenclature of hashtag no going back. Building into our models of care moving forward has to be that focus on making sure that people are looked after where they want to be looked after, and that isn't in a centralised location in the middle of Truro. Our cancer standards continue to be good given the pressures that are on the rest of the services, and I think we should also be very, very supportive, grateful and amazed by the levels of sickness in our staff who this time of year we would be expecting levels of sickness, put COVID on top of that, put stress on top of that, and our sickness levels are looking remarkably good. We are working really hard to make sure that we can provide support to all of our staff, but particularly some bespoke mental health sessions with an external provider for those people who are most affected, but both by COVID personally at work and by COVID at home. So I'd just like to finish off by comments I made earlier around our recovery and restitution. It needs to start off around looking after our people, and we have for a while not had good appraisal rates. I think this is probably going to be our segue into showing people we care by giving them a good appraisal, making sure that their support and training needs match the jobs we're asking them to do, including mandatory training, and for some of our staff now picking up the very practical implications of long COVID. So with that as a background into the IPR, Kim, could I ask you to go through your elements of the IPR first, please?
Thank you, Kate, I will. So if I start on page 44, I know that you've spoken about our absolute determination to look at reducing our falls. As we all know, we had a really good effect of our integrated falls action plan, but for the last 3 months we've seen a steady increase, and we know this is around some of the pandemic effects. So we have our patients now, we have full occupancy. Our patients who tended to fall, which are vulnerable and elderly, were traditionally cohorted into definitive wards or clinical areas. That isn't happening at the moment because of the pandemic. And not using it as an excuse at all. We've realised that patients coming in have a higher level of deconditioning. So don't forget, lots of our elderly, frail, vulnerable have not left their homes. Some of them haven't left their homes since the onset of the pandemic in March. So it's recognising that deconditioning. I think it's really, really interesting. There's some national data coming out now that suggests that between 15 and 25% of our patients over the age of 65 who have COVID will have elements of delirium, which then often leads to falls and other injuries. And it's being recognised now as the most common side effect of COVID. So we are going to do some work around that, because obviously what we've recognised with having the meaningful activities coordinator is A, the success, but B, often staff focus on what I call the more active, so the patients who have definite delirium that are probably more loud, wandering, are the ones that are concentrated on, but there are a group of patients who are vulnerable who have a quieter form of delirium, and if we don't recognise signs of delirium, we often don't do the correct care pathway, which, oh, I've got an echo. Is that better? Yeah, so they often don't are not put on the correct care pathway, which then delays their date of discharge. So we'll be looking at that. We're also looking at the number of falls per month who fall after they're found to be medically fit for discharge. So in December, we had 24 patients who fell that really technically should not have been in our acute hospitals. So we'll continue that work. The only thing other thing I will raise is our C. diff rates are still above where we would like them to be. So we had 4 over the month. However, our new Deputy Director of Infection Prevention and Control did a fresh eyes review. So we've started 2 new things. We're looking at a clinical team that goes around on a Friday with members of the ward staff, looking at symptoms, treatment of patients who've been diagnosed in the last 7 days, and working with the teams to make sure that we've got the right levels of care and support. And we recognise that our misting machine that does the deep cleaning is of an older make, probably like me, and needs renewing. So we're just out to procurement to make sure that we've got that absolutely up and running. Safety checklist absolutely remains our focus, which keeps us safe in ED, and we're continuing to do our work, especially where patients are waiting on ambulances. And I will leave it there.
Thank you, Kim. Bernie, would you like to? Sorry, Mary. You're
something. Beg your pardon. Do you want us to keep questions to the complete end, or can I just pick up one thing with Kim?
However we want to do it, yes, that's fine.
So, thank you, Kate. So there was just two very quick things. One is to note that the pressure on ulcers remaining low, because it's good to note the good things as well as the more difficult. My question was about custom difficile being above tolerance, and just exactly sort of how we're going to get that back again.
So Maury, we do a root cause analysis on every C. difficile case. There are very few that we can pick up that have any what I would call contributable factors, but we are continuing to look at antimicrobial prescribing, which is our use of antibiotics. Again, working with the medical and the clinical teams, the Friday round is key critical to make sure if we're going to pick up any themes or trends that might not have been viable, and there will be a fresh eyes review of the C. diff by the Deputy Director of Infection Prevention and Control going through QUAC where are we now, at the end of February, so we'll pick up any new themes and trends.
Thanks, Kim. Thank you.
Bernie, would you like to come in now, please?
Thanks, Kate. So I just want to focus on two areas on page 55 and page 56. So in relation to our planned versus actual staffing hours, we're reporting around 90% for December. That has dropped to about 80–85% aggregated position for January. As people know, we monitor our staffing levels twice a day through the Safe Care meeting, and that also incorporates system partners so that we can manage risk across organisations. We have heard today that we've got 40 third year placement students coming into the organisation for next week, which will provide some resilience support and some positive learning environments for those coming in for their remaining placements. And we've also had started this week, which Kerry will talk about later, 18 department work and pensions placements that again are deployed as care buddies across the organisation. In response to the CNO's call for 0 vacancies, we currently have 106 band 2s in the pipeline, of which 20 have started since December, and we've got some additional support with our HR partners to get another 37 with start dates this week and another 37 in the pipeline. So we are well on track in terms of meeting that ambition by the end of March. On page 56, just want to refer to duty of candour, which is currently at 90%. There are 2 remaining cases that are just being followed through to conclusion, and just want to talk a bit in relation to our complaint response times, which people know dipped a few months ago. Performance is back up to 74%. The teams are working really hard with the central team to make sure that those outstanding complaints are responded to in a timely way. Some themes that are coming through are concerns in relation to visiting in particular, and also in relation to timeliness in terms of answering phones at ward level. In response to that, we've done a review in relation to ward clerk and have put in additional ward clerk resource, particularly at weekends, to 1, support the skill mix, and 2, to support those clinical teams and making sure that there is regular contact with patients and their families on top of the work that we're doing with Stay Connected.
Thank you, Bernie. Just before we move on, Kim, Adam Broom's just asked that great to get the update on C. diff. Do we have the time frame which the new cleaning machines will come in?
I am just checking as we speak.
Okay, thank you. So then could we move on to Alistair, please?
Sure, thanks, Kate. So just two areas really, which on page 48, which is our sepsis. We're continuing to do really well in our inpatient wards and most of our admitting areas. ED remains a challenge, but we have Mark Jadab is our sepsis lead in ED. They have a sepsis improvement group which meets on a very regular basis. And when we had our dip in performance, we did root cause analysis on all the patients that didn't get antibiotics within that first hour. It's clear from the detail that I'm getting back that we're absolutely on every patient that doesn't get their antibiotics in the appropriate time, and we know why that is, and that they've got action plans to improve that. So there's some narrative in the box which gives some detail around that for the last month audited. Our mortality figures in terms of HSMR and standardised mortality ratio still remain green, in that they are both below both national and southwest averages for mortality over the last few months, and our crude mortality remains stable. So nothing else other than those to report this month.
Thank you, Alistair. Sorry, I couldn't find my mute button. So now I could ask Kerry to come in, please, if there's no questions for Alistair. Kerry?
Thank you. You've already picked some of this up, Kate, but the continued areas of focus with the care groups and our People and OD partners is around the improvement plans for appraisals and mandatory training, and they are at individual levels so that we know exactly who has an appraisal, when it's booked for, and also who has what outstanding on their mandatory training, and again when it should be completed by, and that's reviewed at the performance reviews, and they were discussed last Friday. In relation to the locum training, we have worked with the care groups around making sure we increase the compliance of our temporary staff and workforce, especially in relation to mandatory training, and it's especially focused around the long-term locums that are placed with us, because we need to make sure they are incorporated and included as any other member of staff for their safety and for the patients. In relation to sickness absence, we know that we still have a third of our absences related to stress, and we've currently revised the model of occupational health so that we've moved from a traditional counselling 6-session model to a much more blended approach with therapeutic interventions, and we've got a different skill mix now in the team. The team are currently out to advert for an occupational health psychologist, which will complement our employee assistance programme, our water therapies, our wellbeing coaching, and our art and sculpture therapy. Our hospital chaplains have been supported by our COVID fund to increase the hospital chaplaincy support, because they provide an incredible support to staff on the wards, and we are continuing to extend the number of people, colleagues across the organisation that have mental health first aid training so that they can support colleagues, because that's been a lot of the feedback from staff, is that they don't always want their manager to support them. They want that kindness and compassion and somebody to talk to who they work with every day. So we're further developing those skills. We have had feedback from our triumvirates that they would like us to do a targeted approach for leaders with our health and wellbeing coach. We currently have running a number of weekly wellbeing sessions, and they're targeted around managing in chaos and ambiguity, and how to manage fear and risk and increasing resilience. But what they've asked us to do is focus on training for them over the next few weeks and months regarding resilience within teams and how they can best support their teams, and making sure that we implement the going home checklist is one of those key areas. We have the ongoing focus around reducing our vacancies, and that is steadily coming down. We're currently at 6.7%, and as Bernie's highlighted, we have a national requirement to have 0 HCA vacancies by the end of March. And the work and our partnership, which I know we're going to talk about later, one element of it regarding Kickstart, our partnership with the Department of Work and Pensions is working really well. We have 18 staff currently working with us as care buddies, and their feedback has been great because they're new to care, and we are positively supporting reducing unemployment, both in terms of RCHT, but really proud to say that we're working as a whole system. And so whilst we have 18 colleagues, there are a number of new colleagues that have joined all care partners, and something we should celebrate is that over the last year that we've been working collaboratively and doing joint recruitment and sharing our staff, we've reduced the care sector vacancy rate by 2%. It's still high, it's 11.9%, but it has reduced significantly. I'm happy to pause there and take any questions.
Thank you, Kerry. Any questions for Kerry before I move us on to Tom? No? Tom, please. Mary, was that around appraisals?
Yes, I couldn't type fast enough. I can speak faster. It's ever so brief, Kerry. It's only just around the appraisals and, you know, really putting energy into this. And this is genuinely not a challenging question. It's a gentle question that says, given that we've not had great success before, despite best efforts, what confidence, what difference is it that's giving you confidence we can do that?
So we've got new people and OD partners in all of the care groups. We've worked with all colleagues, including yourself, Mary, around revising the appraisal process. And the feedback that we've had from the care groups recently is that we still need to focus and slim that down. So that's what we're doing at the moment. The conversation we have talked to the people and OD partners around supporting the leaders in their care groups is very much around the well-being question, followed by what training, development and support is required, and making sure people have feedback. And we're not being prescriptive that they have to fill out a 3-page form or that it has to take 2 hours. Even finding half an hour to sit and have a socially distanced cup of tea to talk through with those individuals, how working for them is helping and what support they need is really useful. And we know that it helps us with retention, and we know that when we've got an engaged workforce, it reduces our patient mortality. So it's around us educating our leaders around it isn't just another duty, it is really valuable and vital in the resilience of your teams, making sure that they are classed as individuals, but also promoting that you can do team-based appraisals, because understanding how teams are, if they're comfortable with that, is also okay, as long as you're not talking about specific individual requirements, because we now do team-based rostering and team-based flexible working. So that again enhances the sense of team.
That sounds really good, thank you.
I think we have to remember in this that we've still got a workforce who are recovering from having to work in one way, and that the discretionary part of management is the nicest part sometimes, because it's when you get to tailor an approach to the person in front of you. And we need to be really clear that it's not a permission, it's an expectation. We're expecting people to be flexible and lovely. So I think when we bring the appraisal stuff out, it needs to come with some do's and don'ts almost that are permissive and are around me, you, whoever. Tom, you had a question, I think.
Yes, it was actually a point on appraisals. So as Kerry mentioned, we discussed appraisals at length at last week's performance reviews, and we understand that medical appraisals were part suspended in the initial phase of the pandemic. But the real message that we try to get across to our care group leaders was that whilst it may seem obvious on a day-to-day basis that due to the sheer operational pressure that we face, we need to deprioritise appraisals, when actually there's a real reason for prioritising them at this time, because our staff are working under such difficult circumstances, and therefore appraisals are a chance to do two things. One, to make sure that staff know that we absolutely recognise and appreciate their efforts and hard work and dedication. And secondly, that they feel supported in going about their duties and their role, particularly given the psychological toll, as well as the physical toll that these difficult working conditions are having on our workforce.
And there's also been a cultural shift that if we want to keep it, we have to notice it. So when Robin was talking about how the site's working, our surgeons are sharing surgical space. Our physicians are protecting surgical capacity. Our sites are choosing to take different groups of patients. All of that is discretionary. All of that's a choice. So I think if we started appraisal processes now, it gives us the opportunity to tell people how amazing their personal choices are, and what does that mean in terms of your training, support, supervision next year. So I think now would be a really good time to start. So are there any more questions for Kerry before I then move us on to Robin? No, Robin, is there anything you want to add? Your COVID presentation was very fulsome. Is there anything else you'd like to pick out of the IPR?
Thank you, Kate. It's just, I think the important thing is for our standards, we are still struggling with that. And we must remember that as a whole system, we all signed up to making sure that we deliver our COVID security first. And that was a meeting that was chaired by yourself, Kate, with all the clinical leaders, GPs, etc., agreeing that it's more important right now that we don't break our own COVID rules. What we do have as light in the tunnel to that is we have these additional analyzers coming. They're called Samba analyzers. We've got 4 already in ED and there's more coming. Those analyzers allow us to do more rapid testing of patients, so we know their COVID status, and it will become easier for us to move them out of the department quicker. And as you already said, Kate, we've already done a self-assessment against what's considered by NHSI as best practice for avoiding ambulance holds, and working closely with my counterpart in SWAST, Jeff, we are going to try something new from tomorrow as well. So we are constantly checking and challenging ourselves. Is there more that we can do for ambulance holds? Because none of us want to see a held ambulance outside our hospital. I think that's all I need to add. Thank you.
Thank you, Robin. Richard Stevenson, did you just want to make your point about lived experience and appraisals being helpful for that? You're on mute, Richard.
Yeah, it's under. It seems to take about 10 minutes to allow me to speak. Apologies. No, it was just the point really that actually at this time, particularly in the strange environment that we work in and the exceptional circumstances that people are working in, appraisals obviously give us a really good chance to just flush out those learnings from people about the lived experience. And that might help us, that does help us innovate practice. It helps us look at different ways of working, and it helps us to look after our well-being, care of our staff, whilst finding better clinical solutions. So yeah, it was just support of driving on with the appraisals at the earliest time. Thank you.
Thanks, Richard. So Tom, I think you're last for the IPR because we cover finance separately in the separate finance report to the board.
Yes, thank you. And in terms of the remaining Brilliant Improvement KPIs, there isn't that much in the core report because we're currently operating with a streamlined IPR during the pandemic. What there is on page 63, which is Appendix 2. We've got the Brilliant Improvement Summary Dashboard, and you'll see the second half of that. We're 140 trained QI ambassadors in the trust. The percentage of those that have completed their in-house QI training at 0% is incorrect. There was a training session held in December, and that was attended by 100% of those that were meant to attend it. So that's an error in the data. So apologies for that. It's not 0%. In terms of live innovations, we continue to perform well above our month-to-month target with regard to the number of clinical innovations that we have running. And with regard to research and development trials, I think I covered this at the last board meeting. But both in terms of the number of patients recruited to trials and in terms of the income that those trials have generated, we are way ahead of our pre-year trajectory. In fact, as at December, we'd already exceeded what we achieved for the full year last year with regard to both trial numbers and income. And that's largely due to our COVID activity, both in terms of the Siren study, where we've been the most successful recruiter to the study in the Southwest, and also with regard to our involvement in the trial of the Novavax vaccine, which we are hopeful will be licensed for use in the forthcoming weeks. That's it. Thank you, Mari.
Thank you, Tom. So that's amazing news. A great point to finish. And Adam, your suggestion that when directors are pulling out specific things from the IPR, the packs are so big, it's great if we could all do what Tom does and just point out which electronic page we're on. So that's the IPR, Mary.
Thank you very much, Kate and exec team. I think that has been a good discussion, although it ran very slightly over the time. I would just want to note that the committees have all discussed their part of the IPR. And so there has been quite considerable depth discussion of the IPR. And I'm wondering whether, in the light of the discussion we had at Board Informal last week, it is the best use of the time to use committee to discuss and board to discuss. And I think it would be perhaps good if the next round of committees had a bit more thought about whether there is added value in them discussing them, and just how we take this approach to the IPR at board better. So we get the full board overview of the IPR, but that's just to ask committees to do in the next round. So before passing on to item 9, if we could please use the chat to note that we are noting the IPR for the period to the 31st of December. And if you could go on doing it until we've got a chorusy noting, thank you very much. Keep going. Carl, if I invite you to do this, I won't say anything about coffee is waiting, but I will warn you that have got 2 small questions on this report, but they're very small. So over to you, Carl.
Thank you, Chair, and a very short report from me this month. If we can just split it between the revenue position and the capital position. So on page 93 of the pack for colleagues, just the key points from the finance report. We continue to have a relatively positive position on our revenue position. We're ahead of our plan with a smaller deficit than planned by £1.5 million. And the reasons that are set out there are in the main reflective of the activity issues that Robin pointed out. So our activity is lower compared to some of the projections we set when we set the second half year plan, and that we have not incurred the level of expenditure on some of our provisions that we made in setting that plan, as well as a number of technical issues. So at the moment, our revenue position at the £1.5 million under plan is also then starting to reflect the potential for a improved forecast outturn. At this time, however, as you'll have seen in the briefing, I've not changed our forecast outturn for a number of reasons. One, that we still have to understand the impact of what's called the elective incentive scheme, which is a calculation based on the elective activity plans that we set as part of the second half year plan. And obviously, as we know and talked through, that activity will now be lower than originally projected. So we may have to see a reduced level of income based on our planning assumptions. We don't know what that is yet because we're awaiting the national guidance. With the national guidance also set out around holiday pay accrual, and of course we know the challenges we've got with people being able to take annual leave, that we are waiting further guidance as to what the expectation is around the accounting treatment for that holiday pay accrual. Now, whilst there were an estimate built into our planning assumptions, the level of the accrual may actually be materially different. So that is a known issue with our financial position with regulators, but it's also another reason why we haven't changed our forecast outturn. The board will also be aware that the financial plan is based around not only RCHT's position, but each of our partner organisations achieving our collective financial position as a system. There is nothing to bring to the board's attention at this moment around both CFT's and the CCG's position that could impact on our own position, which is also helpful. But at this time, until we get a collective view on our each of the organisations' forecasts, obviously we won't be able to report on any changing position. So on the revenue side, it's a positive position. We'll have a better feel for the forecast at month 10 once we've assessed other COVID related expenditure, because we know the organisation is completely challenged as we've set out in the operational position, and we need to understand what the revenue impact of that is once we get through to the month 10 position, which will be in a week or two's time. So I'll pause there for me, Mari, just to invite questions on the revenue side, and then I'll touch on the capital position.
Thank you very much, Carl. You have actually answered one of my questions. It was on 3.7 on the holiday pay accrual, so thank you. You've covered that. But the only other point, and it's not a question, I just wanted to note at 3.5 on page 93. I just wanted to note the concern about this, because this is something we've worked hard to get a grip on around the agency expenditure. And I know it's only a small increase, and I know we're in the middle of winter, but I guess I just wanted to note the concern that we keep the key lid on that.
Thank you, Mari. And what I will do for next time's meeting, and we obviously we've got we have a more detailed discussion in the Finance Committee, and Richard might want to add to that in his brief later. I'll do a slightly more detailed report to the board that looks at the overall pay costs, not just the agency, because it obviously is a composite position. We are underspending on pay overall. So any variation in the agency is being contained. The interesting point, and reflecting on Bernie's point around the healthcare assistant appointments, obviously we should see a commensurate effect on our bank overtime and agency when those staff come into post to fill the vacancies. And I think the numbers that we're talking about are reflective of our vacancies and trying to close down all those areas that we can at that band 2, band 3 level. So the overall management of agency control remains in place, but I'll bring a slightly more detailed report to board next time.
Thank you, Carl. Kate, you wanted to come in, and then I'll report what you just said, Kerry.
So I think we just might need to be clear about breaking down what agency means. So although our sickness rate's good, we've still got people going off with short notice sickness with COVID, and that's not just nurses, it's doctors, anaesthetists, surgeons. So we need to break down what the agency is, and we also need to reflect that our joint bank with, our integrated bank with CFT and with Cormac, we are servicing all the care homes in Cornwall so that we can try and support them in looking after the 220 odd people who've got a positive diagnosis of COVID in their own homes, rather than the default being coming into the hospital. So I just think for agency, we need to just for now, we need to be really clear what it is we're talking about, because it wasn't what we were talking about before, i.e. Thornbury nurses on the wards. It's a more of a finessed thing. Doesn't mean to say we shouldn't be looking at it, but I think we should understand what it is we're looking at.
Thank you, Kate. And Kerry and Bernie are both giving assurance of ongoing focus on agency and bank spend against the plan. And Bernie saying tight agency controls remain in place. So thank you very much for that. Carl, I'm not needing to bring Richard in to add to anything that you said, because he believes you've covered it and he'll pick up anything else in his report. Do you want to go rapidly on to the capital?
Thank you, Mary. And the capital position is more challenging. So as colleagues know, we have a significant capital programme this year, £59 million, which is a mixture of funding sources around our standard capital programme, noted as CDEL, Capital Department Expenditure Limit, to avoid the acronym in on my report. And a whole series of additional capital allocations based on some of our major schemes: oncology, MRI relocation, the work around the ED resus expansion. Now, in terms of the meeting that level of expenditure, whilst we are on track to date, we are obviously managing a relatively back-ended programme, and we will talk in the boarding committee around options to manage the risk of what is at the moment a small underspend against that overall programme. We have options, however, to meet our capital targets, but it will continue to need the focus of all the executives and teams that managing aspects of this capital programme around medical equipment, the buildings programme, the digital programme, and of course just core replacement of our asset base. So we'll talk more this afternoon, but this is the area that I think that I personally will maintain focus on and report to the board. The one area where we do seek approval, Mari, is around, we have now had positive confirmation of the additional funding to continue the work on our Lowen and MRI project, the oncology ward, which enables progress between approval of the FBC by the Department of Health and the completion of works the enabling works before we start the major build programme in 2021. And on that basis, I'd ask that we support the receipt of the 1.4 million as set out in the recommendations.
Thank you, Carl. Has anybody got any questions on the capital part of the paper? No. Thank you. In which case, I'd like you to indicate on the chat, please, we're asked to note the financial position to the 31st of December 2020. And as Carl has just said, we're asked to approve the acceptance of 1.4 million in public dividend capital and commit expenditure of 1.4 million from within the capital programme to continue the low-end MRI project during February and March 21. This will be in advance of receiving approval of the business case from NHSEI and the DHSC. This expenditure is in line with the business case approved by the Trust Board for the project. So please could you note and approve until we have sufficient. Kate, are you wanting to ask a question? I'm sorry.
I just want to be ultra picky. The Department of Health and Social Care and NHSINE are giving us this money in the full knowledge that the full business case hasn't yet been signed off. And it's with that full knowledge that we're proceeding with the enabling works. Carl, I just would like to be very clear on that.
I think that's incredibly important, and absolutely, we submitted an application through the approved routes to the regulators to seek this funding. They've approved it. This is on the back of the receipt of what's called a memorandum of understanding from them for us to now sign, which I can now sign on the back of the approval.
Thank you.
Thank you, and thank you for that, Kate. Really important. In which case, I don't know what time it is. Right, it's 11:41. I propose we take a 15-minute break. Only it's going to be 14 and a half because I'd like us back at 5 to 12, please. 5 to 12 restart. Don't forget to turn off your sound and your video. Welcome back, everybody. Thank you for taking the break as we did, and I'll be assisted by everyone in moving us through to our next break in good time. So if we could then come to item 10, and I'm going to invite the chair or the representative of each committee to provide a summary of key aspects discussed. I just note that I'd missed off the list the meeting of the Remuneration and Appointments Committee held on the 29th of January, and I will invite Paul Hobson to give that update after the update from Quality Assurance Committee. But Paul, I'm going to start with you and ask you to do the Charitable Funds Committee held on the 12th of January.
Thank you, Mari. One of the roles of the Charitable Funds Committee is to act as on behalf of the corporate trustee of the RCHT charity. And in doing that, at our last meeting, one of the things we did was to approve the annual report and accounts for 2019-2020, a copy of which is in everybody's pack to review should they wish to. And one of the formal functions we need to undertake this morning really is the board are invited to ratify the approval of that annual report and accounts. So if we can do that during the course of me talking, unless there's any significant questions, that would be quite useful to be seen on the meeting chat, I think, so that it's clear for Sean on that side. We also, in that same guise as the corporate trustee, considered the external audit plan during the meeting and had quite a discussion around the various elements of that with our external auditors, resulting in the approval to sign the letter of resignation that is required again by the auditors. And subsequently in that role, we endorsed a funding request by the Trauma Research Fund to use legacy fund that they have to create a research prize in the name of that legacy. The other duties we undertook during the meeting were to discuss, as we usually do, and note a range of issues, one of which was the move towards appointing a head of charity to help us focus and move forward the overall charitable function and also aim. And we did something first time for since I've been involved, whereby we had the heads of the funds. A lot of the funds are actually managed locally, if you like, by the various departments and wards and such like. And we invited the fund holders to come in, and we had a presentation from both the Headland Unit Fund and also the Cancer Research for Cornwall Fund, which was very enlightening to us and very useful. And it's a process we will continue in future months, because it gives the committee an insight as to what the monies are being raised for and used for. And more importantly, also, I think it gives the fund holders an understanding of our role and how it all joins up together, really. We had a great presentation, usual, from the friends of the RCHT and also our own fundraising team, and that was always well endorsed and well appreciated. And we did our usual bit of reviewing the current financial position, which is an ever-changing position at the moment, as investment funds sort of vary due to the overall financial position. So that's about my report for the moment. Thank you, Chair. You're muted.
That was really interesting, and I really like the idea of bringing the fund holders to the committee. That sounds very successful. I think, Kate, you were just wanting to note it would be a good thing for us to have a focus on the charity at Trust Board in one of the future meetings.
Yeah, you know, when you read through the annual report and you see the people who've got the things that they wanted to lead and are proud of,
yeah,
faces in their environments. So it's just something about for our public. They may not necessarily get access to the annual report. I know it's available, but it would be great for people to come and showcase the difference that charities made through their ability to care. I think it would be really good.
I think it's an excellent idea, Kate. I think that would go down very well, because we're trying to grow at the moment. I think that the whole charity are trying to grow its presence, if you like, so it's more noticeable and more understood. And I think that would be one mechanism to aid that. So that would be appreciated, I think. We'll look at that going forward.
We could do that as part of the patient staff story one month, and you know, it would be good for you to choose the month, actually, Paul, because you know, if you've got something big coming up, it would be a good showcase, because we do get a large number of public now watching our public boards, so that would be a great showcase. Yeah. Any other questions for Paul?
Oh, Carl's got one.
Carl?
Apologies, I couldn't find my button, as they say. Sorry. Too much jollity at the board. Just to reflect the financial elements of the paper, that the audit opinion was very positive, colleagues. So there is nothing to bring to the board's attention around the annual report financially, and the accounts were signed off by our auditors.
Thank you. Thanks, Carl. Paul, I'll take the approval, if it hasn't already happened, right at the end of this section, and I'll ask people. I'll read it. I'll read it out. Thank you, Sarah Newton. And with thanks to whatever God created your Wi-Fi again for you, it's good to have you able to give this report. You're going to give us the Audit and Risk Committee report of the 14th of January this year.
Thank you, Chair, and let's hope the internet connection holds up for the whole report. Yes, we had a really good discussion around our board assurance framework and corporate risk register, and we were concerned about elements of this. So it was escalated to the full board, where we had an informal meeting in January. And I think that was a really useful day. The areas of concern that we had were the safe use of radioactive materials and risks associated with the ongoing problems that we have with fire safety and some aspects of health and safety of our staff. So I think that we had a really good day where we were able to seek a lot of assurance because we had more time to go into details, and it was really good to hear Kate throughout this meeting really reflecting back the whole board's considerations on those issues. We also discussed and approved a new declaration of interest policy. Sian, our company secretary, done excellent work on that. That's now live on ESR. So just to encourage us all as board members to lead by example and complete our declarations of interest on electronically on ESR. We'll need to do that every year, just not when we join the board. We also looked at our external audit assurance. Our external auditors were with us, and we're looking at our timetable for this year, and understanding that there might well be issues with the stock take on the inventory as a result of COVID. We had a good discussion with our internal auditors, and the committee sought further assurance around the timescales for the new plan. And we did challenge some of the targets not being met in terms of follow-up actions which were agreed. And we had a particularly good discussion about an important aspect of our work, which is to make sure that the CQC targeted inspection findings were incorporated into our internal audit plan. Then we had a discussion about the role of our committee in light of integration. We've heard that that is going forward. We can go ahead to the next stage. So we looked at the Audit Committee Handbook and information from NHSI on transaction guidance, and we've decided to work with the CFT Audit Committee. So I've made touch with the CFT Audit Committee Chair, who's responded back that we are going to start working together to make sure that both boards can receive appropriate levels of scrutiny and assurance about our integration work. Then we also noted our annual review of external audit effectiveness. We didn't really have time to do that justice, so we're going to be looking at that again at our next committee meeting. We received counterford an interim report and single tender actions and losses and special payments, and there was nothing of note really to report to that. Everything was in order. Thank you, Chair. I'm very happy to take any questions.
Mary.
Thank you, Sarah. That sounds really thorough and good directions there. Has anyone got any questions for Sarah? No, I think for the members of the public, just to let you know, the composition of that committee is that the chairs of all the other committees sit on that committee alongside other members of the board, but I do not, so we don't mark our own homework. Kate, sorry, I cut across you.
I was just reflecting on Sarah's point around the two audit committees have met to talk about our integration, and I do wonder whether with the two audit committees and Tom as the executive leading the integration programme, we might have our own, you know, if we were doing a reconfiguration, we'd have the gateways that we go through. So what are the milestones that we as organisations should be stopping and looking at before we get to the stock take full business case? I did just wonder whether that might be something we might have two audit committees to do with Tom, so that we bring integration and audit into one space.
I think at this stage, Kate, we've just agreed that the two committees are going to meet, and we're going to meet informally to look at the scope of what we should be doing, and we'll very much welcome that suggestion, and we'll work with Tom to develop a proposal which I can take to that meeting with our colleagues in CFT to agree a common approach.
Thank you.
Great, and Richard, you're just saying it's good proposal around the gateways to be considered. So thank you for that, Sarah. I think that's very helpful. I'll move us on then to the integration committee itself, which met on the 18th of January. This committee is chaired by Margaret, but I sort of co-chair the committee, and we received the regular programme update report, and we reviewed programme risks. The majority of the meeting was reserved to hear from each work stream lead or their deputy on the tangible activities that had taken place so far. And that is all around looking at more integrated working, plans for the forthcoming year, current barriers to closer working, and the benefits that integration will bring. I think what the committee found most helpful was hearing the actions being undertaken, because up until now there's been a lot of vision and thought for why it's good, but actually to see some of the actions now happening was great, and the committee wanted to thank those people who are leading this. And also, Tom, if I may thank you now, because I know quite what a lot of work this is, and it is moving ahead in a good way, and that's thanks to all the work being put in. The other point to note in that section is just that, as I mentioned earlier, we do have regular board-to-board meetings with our CFT colleagues and explore the various aspects of our integration, and we've been doing that very thoroughly recently, and we have another board-to-board meeting, I believe, Sian, it's next week, I think the 17th. But those meetings that are informal meetings are, I think, building up real value. And you heard what I said earlier about the buddying scheme. And thank you, Sian, you've just told me it's not 17, it's the 11th of February, that next meeting. Does anybody want to ask anything about that committee? In which case, could I then bring you in, Richard, for the next two reports? The first is your own committee, the Finance and Performance Committee, on the 15th of January.
Thank you, Chair. So the committee had a number of items for approval, and so I'll talk through those. Then we had some for assurance, and then we had some for noting. So issues that came forward for approval, we had the opportunity to draw down public dividend capital as an award to put against the static mammography screening units. There are 3 units. We hadn't received a full and signed off a full business case for that, but we had already received a full business case and signed off on 2 mobile screening units. The committee took the decision to approve receipt of that public dividend capital to progress those works, obviously the value of which takes it above the board's own the committee's own approval, and that was recommended for e-governance to the board, and we will be discussing that with board and committee this afternoon. We had an item for approval around junior doctor rota change, which is effectively a revenue business case in that it brings a changed workforce, additional workforce into the trust in order to make sure that we comply with national requirements, and particularly around national safe working, but on junior doctor rotations. We approved that in principle, but have asked for some further detailed work to be undertaken just to ensure that the current planning is aligned with our transformational processes, and we can be assured that they will dovetail in the future, and that additional work is going to come back to the Finance and Performance Committee in February. We also received a shared care record outline business case. This is across a number of trusts in the Southwest to look at the procurement jointly of a, as it is, electronic care record database. And we approved that at the outline business level case to go to full business level case. That means that we have to put some investment in again ahead of the full business case being signed off, but it's at no risk in the sense of we haven't committed to funding into that system. It's at the point of securing procurement and to develop the full business case. So we took that on behalf of the board. We received a report into the West Cornwall Hospital redevelopment project, and again we've approved the next phase of that development scheme to move it on to full business case, and that will come back to a future board. And we've recommended a number of contracts over the £1 million report to Trust Board, which will go to Board Committee this afternoon. Items received for assurance. We had a new report which we very much welcomed, which is a post-project evaluation update. We'd scrutinised the scheme of delegation, and for all of our project evaluations, we think that projects that have been approved at board level, those that are over £1 million or at a level of risk, should come back to the board for approval. At Finance and Performance Committee, we can look at those projects that have been approved and go back for evaluation at Finance and Performance Committee. We had the first of those reports with us at this meeting. We very much welcomed it. We will receive those every 6 months from here on in, and we are doing some further work just to enhance that evaluation. As we've already discussed in board today, we received the month 9 finance report. As Carl's outlined on the revenue position, we're in reasonably good shape. We did have a look at agency costs, but we also received assurances around the governance of that. And we also, as Kate outlined earlier, understood the differences between the activity that's occurring now in COVID and that which was occurring as a baseline trust commitment prior to these circumstances. In terms of capital, as Carl alluded to, and as we've now done the approval around that 1.4 million, the risk is more concerning around capital in ensuring that we meet all of our capital commitments throughout this year. But also we are mindful, and there's further work to go on about the revenue implications of the capital developments that are going on for future years. So beyond month 9, just ensuring that we're not storing up problems for the future. We received for assurance a backlog maintenance and estates and facilities report, and we're given good assurance on the operational progress of that, and required some further assurance just around some staffing to make sure that we're delivering that. And we noted the security arrangements updates relating to the additional security required for COVID at this moment in time, including some of the additional requirements that might be needed for the mass vaccination programme. We did receive, as alluded to earlier, the revenue consequences of the capital programme. That is going to board in committee this afternoon for further work. And we noted the temporary streamlined integrated performance report, as Tom alluded to earlier. That's already been discussed in board. We also receive a report from the Building Brilliance report, which is our master plan around estates and all of those capital developments and estates developments that are going on. That's for noting and report at that committee. And we received a report on the patient level costing information, and as you alluded to earlier, Mari, the 2 awards that have been given to that team, we were able to thank them and congratulate them in person. Happy to take any questions. It was a full agenda. I apologise for the length of the report.
Thank you. Thanks very much, Richard. That's that was also a very full report and helpful. Do colleagues have any questions further for Richard? Paul, you look a bit as if you might be about to speak, but no? Okay. Okay, thank you. In which case, Richard, if you've had chance for a quick sip of water, it's over to you again. And just to note that Richard is kindly chairing the Quality Assurance Committee since Margaret Schwartz left. And as I said earlier, we have got advertisements out. So thank you for doing that, Richard. And next report.
Okay, and Chair, just before I move on to this report, I'm noticing in the chat that Sian has just corrected me on the grounds that the shared care record outline business case has been recommended to go to full business case to the board for approval, and that was taken on the board decision on the 28th of January, so that was approved by the board. My apologies. On to the Quality Assurance Committee reports then. There are 2 meetings that we engage with. Sorry, I'm getting a bit of feedback now. The Joint Quality Assurance Committee, this is between the Trust and with Cornwall Foundation Trust. And as was said earlier about the audit and risk, we are attempting to put more items into common ground of a joint Quality Assurance Committee where our integration benefits from understanding and scrutinising those reports collectively. And so we had a number of items to look at this in the January meeting. We endorsed the restricted visiting guidance. So as was talked about earlier, that is updated every 2 weeks. It comes to this meeting for endorsement and understanding. So we give that the full scrutiny in terms of our position where it may be changing or where it is remaining static. We received an integrated safeguarding COVID-19 briefing. This is the issues that are rising specifically around COVID, but also aligned with the integrated safeguarding Q3 report. And we received good assurance on the mechanisms that are being captured across all cases and the delivery of the support required across the system. We received an assurance report around lessons learned from COVID-19 pandemic. and looked at the preventative, educational, procedural actions being taken and to be taken as next steps, and again received good assurance they aligned. And we received and noted the Infection Prevention and Control Board Assurance Framework. That's on our agenda for Public Board this afternoon, so I'll say very little about that. And we also received an assurance on quality and safety and how it would be monitored throughout the third peak of the pandemic. So just making sure that our health and safety issues are receiving the full scrutiny that they require, despite some of the challenges and additional challenges of the pandemic. I'll move on to the specific Royal Cornwall Hospitals Trust Quality Assurance Committee. Again, a very full agenda. I'll take those items which we approved as the committee. So we did receive the Health and Safety Programme Assurance Report. We recommended that the Trust Board monitoring of health and safety improvement continues to be monitored through the Quality Assurance Committee, with exception reports coming to the board. So that is something specific we wish the board to consider, that they will receive exception, and Quality Assurance will continue its delegation to look at that. That's going forward into board and committee this afternoon, the report itself. We had items for discussion and further assurance around fire safety, and we put a heavy challenge and sought assurance regarding the timescales and trajectory for compliance, and again that is being reported back into board and committee this afternoon. We had the discharge summary programme. We were not assured that the timescales were entirely realistic and have asked for that to be brought back and to continue with quarterly updates around our stretch targets for our discharge summaries. We considered the integrated paediatric improvement plan, and we noted that the integrated paediatric improvement plan had been integrated into the paediatric strategy. So we were able to close the item specifically looking at the improvement plan, but it will be monitored and assured through the quarterly reporting on the paediatric strategy. I think that's on our agenda again later. We noted, our integrated performance report and the ward to board report is on our public board. We've discussed that extensively. The ward to board report is in the pack. Essentially the areas that we scrutinised from that relate to some of the areas in the integrated performance report, so I won't repeat those, but around falls, for example, and some of our agency spend. The committee noted the CQC targeted inspection report. We received that and the action plan. We were assured that that is really well articulated and that will be reported back. We note that that will integrate now into the wider plan, so that the wider plan for improvement for the Trust and the Trust Incident Review and Learning Group report, which we also considered. So they are amalgamated now into one improvement plan. We noted the harm review and referral to treatment times, and Robin's done an excellent job earlier of talking us through the assurance around harm reviews. Alistair commented on that as well. And again, it's worth the board just being very clear that the bulge in the 52-week waiting list is an area of concern due to the standing down of elective treatments. We have all of the plans to restart those and to reduce and manage that and mitigate for that. And we are assured that the harm reviews are ensuring that no one on that list is being disadvantaged by that care. We received and noted the patient safety and incident response framework. That has been aligned fully with CFT's framework, so it will be a joint framework that will be signed off in April 2021. So we aren't signing that off until we receive that as a full and integrated plan to meet the timescales. We noted the senior information risk owner report, and I think that is the business that was concluded through QAC, Quality Assurance Committee. Again, apologies, full agenda, long report. Happy to take any questions.
Thank you, Richard. I'm just going to bring Tom in, but I think probably to say those two reports and together with the charitable funds report do indicate just how much work is going on in the Trust alongside the pandemic. And so though that was a lengthy report, it's very good to see all of that work going on, and we will consider your point about where the discussion takes place. Thank you. Tom.
Thank you. I was just thinking about Richard's comments on the Joint Quality Assurance Committee, and also thinking back to the board informal session that we heard last week and how we derive maximum value. from our joint governance arrangements that we have as two organisations, because Quality Assurance Committee is the start, but no doubt over the next few months we'll be looking to establish additional joint arrangements. And it takes us back to the conversation that Sarah raised just a moment ago about the role of the Audit Committee. I do think there's a very real role for both audit committees to seek assurance that any joint governance arrangements we're putting into place adds value for money and is clinically effective, rather than, say, just adding to the overall bureaucratic burden. I think there's a real role for the Audit Committee in that, if I could suggest as much.
Thank you, Tom. Sarah, did you want to comment at all further, or you already have?
Just unmuting. No, I agree, and that very much came out of our informal board meeting. We'll absolutely work with Tom and come back with, obviously to the board and then to the committees.
Thank you, Sarah. Anybody have any further questions for Richard? No, in which case, Paul, could I ask you to do the Remuneration Appointments Committee on the 29th of January, please? You were standing in to chair in Sarah's absence.
Thank you, Mari. I'll be relatively brief on this. The committee does what it says on the tin, really. It's remuneration and appointments assessment, really, to make sure that there's an overview of what's going on. As such, we discussed and noted a detailed spreadsheet on the executive directors and very senior managers' remuneration and contract status, if I could say it. And there's some resulting actions coming out of that, and that'll be coming back to us at some stage. We also discussed and approved the process for executive director, senior manager appraisals for 2021, and noted that the committee should receive those outcomes and related recommendations in May 21. Finally, we also had a discussion and a review of the trust relocation policy, and noted on that it required updating. So that will be coming back to the Remuneration Committee at some stage. That's about the extent of the report. Thank you.
Thank you, Paul. Do colleagues have any other questions for Paul? I guess something that comes in my mind, Paul, is how people who are not on that committee can access the outcomes in particular. And of course we can through papers, but it's just a sort of mental note, because there are people who don't sit on that committee who would have to take some of those actions to be able to meet that timetable.
I would say, Mari, I think it's the same as any of the committees, because not everybody sits on every committee, and I think it's the chairs of each of the committee, speaking for my colleagues, are open, I suspect, to happily clarify or explain what the actual work or any specific point relating to the work that's been undertaken by that committee.
Yeah, thank you, Paul. I was sort of wanting to let the public know that, and know that the whole board can be involved in those matters. So that's very helpful. Thank you. Kate, you wanted to come in, and then I want to note Sian's comment in a minute. Kate.
It's important for some of our equality and diversity metrics, and if we're going to be looking at inequalities in the broadest sense. Remember last year we started looking at how pay awards were given by gender, and we should now be looking at the complete characteristics of our board and our directors, particularly, that RunCom have a specific responsibility for. So I think it would be good to have a report on an annual basis, almost in the annual report, that talks about our directors and our diversity. We started looking at questions around who got it, and gender splits, and size of salary relative to performance related pay. It's the first time we've done it, and it was a really good discussion, and maybe if we're more open about it, it might be a way that we share with people who come to board, but also the rest of the organisation.
Thank you, Kate. I think that's a really important point. So in winding up this item, can I ask that we have discussed and noted the assurance reports from the committees, and that as corporate trustee, not as board member, we ratify the approval for RCHT Charities annual report and accounts. And I did see, Paul, there was a question from Adam, about whether there ought also to be an audit sign-off from Audit Southwest. I don't know whether either Carl or you, Paul, could answer that question.
I was hoping Carl was going to jump in on that one, I have to say.
I thought you might have been. Come on, Carl.
Yes, I think there should be a letter in there, but I'm not quite sure what it is. Carl?
If I may, I think you're probably referring to the external audit of the charitable accounts. Hence why I pointed out in the committee that we had received a clean opinion from the auditors. It is normal to have the audit opinion in the annual report, and on reflection, I think it may be an omission. It may be a technical issue, and I've just asked my financial accountant to clarify. Yeah, we did receive a clean audit opinion. And if it is technically required, we'll add it into an amended annual report.
Thank you, Carl.
There you go. You see, a little bit of help from my friends, Paul. But
well,
Adam,
everybody needs help.
Thank you for raising the point, Adam. So, discussion and note the assurance report. As corporate trustee, ratify our approval of the annual report and accounts, and also, as Richard said, for us to note the ward to board report that was considered by Quality Assurance Committee. And I will need your written agreement on the chat, please, particularly as corporate trustee. Thank you. So we are running really quite a lot late this morning. I'm going to have to try and see what we can do about it, other than I think that was a full debate and does, as I said, indicate the work that we're doing. So let's just keep going. Now, I've got item 11, which is the Kickstart scene, but we've also got visitors joined us. So we've got Joe and Clarissa ready for the item on freedom to speak up. You're very welcome to be here as we take these items, because it is a public meeting, so it's very nice to see you. I think we should go right on to the Kickstart scheme. Kerry, item 11, and note that this has been, we've been briefed previously on this scheme, which is a national programme, and it's part of our engagement with the Department for Work and Pensions. So Kerry, if you would take the report as having been read, I have got a couple of questions, and I'm sure others have. So over to you, Kerry.
Thank you. As you say, Mary, we have raised this and talked about this extensively, both in terms of RCHT, but also with system partners. So this is a proposal that has been approved by the DWP, and I am asking the board to approve the acceptance of the 1.131 million grant. And that comes to us as RCHT because I, as part of my workforce and OD system lead role, I have nominated, with support of colleagues, RCHT to be the host organisation. It's important to say we have approval for 148 places, of which we can increase those places once they are filled. Kickstart is separate from the other work stream that I talked about in terms of our partnership with the Department of Work and Pension, because Kickstart is specifically targeted at younger people and at 16 to 24-year-olds. We know that unemployment across Cornwall has increased by up to 16,000 just over people, which has tripled since COVID. And in the last 9 months, and we know that young people are significantly affected because actually the unemployment rate in young people has increased by 50%. And this is our approach to bring younger people into care roles that maybe wouldn't have ordinarily thought that they were accessible. And these aren't all frontline care roles. We've worked with partners to develop a significant number of roles, and actually Kickstart promotes that you don't put somebody into an existing vacancy. You do look at different workforce models and different skill mixes, and you give people an opportunity to do a variety of roles that then enables them after 6 months or up to 6 months in the placement to transition ideally into a permanent role which therefore reduces our vacancy rate, reduces unemployment across our county, which is of course the focus, but increases opportunities for our young people to stay within the county, as we are one of the large employers, but also working with our care partners. This is about how we improve care to all of our communities, regardless of which provider, whether they're public or private sector, and making sure that we do look at inequalities in health also. So I'll stop there and ask if there are any questions.
Thank you, Kerry. I think this is an absolutely fantastic initiative. Colleagues, do you have questions? I have a couple, but other people? Okay, I'll roll on with mine while others are thinking. I may have missed it, Kerry, forgive me. I'm just wanting to know whether, I think it's page 177, section 3.2, whether we are going to employ people at higher salary, and if so, what the estimated cost, and whether they work more than 24 hours, 25 hours, sorry. We feel like we're working more than 24 hours, don't we? I might have missed it in the report. It's just a bit around the cost of that.
Yeah, so that's highlighting a risk. What we're not intending to do is pay people different rates of pay, because that presents us with an equal pay risk, which we do not want. We also have tried to have equality for the private and public sector. So what we've agreed as private sector organisations is we will pay a spot salary, which is the national living age-related wage. And we will pay the pension at the NEST 3% contribution, because then we are paying all of our Kickstart placements and people the same pay rate and the same pension contributions. However, they are obviously all going to be supported to apply for roles that are most suitable to them or that they show the most interest in. And when they move into paid employment and permanent employment after the placement, then they will go into the appropriate salary range for that role and the pension for that employer.
Thank you, that's really helpful. I've got a couple of other questions coming up, but I'll just finish mine. I think I was just wanting to understand what any financial risk to the trust is, as opposed to in the risk section, where it sets out the value of doing this. But you've answered that. And then the last question from me was where this sits within the trust governance. So will this be monitored by which committee?
So it will continue to come through the pod committee, and we'll have regular audits with the DWP.
Thank you. So I've got Sarah Newton wanting to come in, Richard Stevenson, and then Kate. And I think Carl just waved his hand. Sarah, Richard, Kate, Carl.
So thank you very much indeed, and I'm delighted with the way that you and the Trust have really engaged with the DWP to enable people who are unemployed to come and work in or to consider working in the health and care sector, and that will help us fill the vacancies that we've heard about. So I think it's a win-win, it really is. Given that the money has been allocated to the system and you are responsible for managing that through and hosting that really through RCHT, I was interested about what governance arrangements have been put in at a systems level for the expenditure of the funds.
So that the programme will be monitored. Well, first of all, we'll have a separate budget code, so it's all ring-fenced funding, and then secondly, we will take it through the workforce implementation group, which is the system-wide workforce and OD group that I chair on a weekly basis. We'll also take it through to the system board and to the Senate. And then we will take it through to each of the statutory sovereign organisations, as we have done to get to this point, so that the governance is as robust as we can make it.
Thank you very much.
Because our system governance does give us a challenge because we're all sovereign organisations.
Thank you very much, Richard.
So I think I understand it, Kerry, so my apologies, and we have trailed this before. When it talks of new roles, does that just mean that they're supernumerary, for want of a better word, for the existing post, or is this new roles? Is this new workforce skill competencies? And if it's the latter, how does that map to future workforce for the trust And is there any implication of cost, revenue cost on the trust if we start to employ people into those new roles alongside, I'm assuming the answer is workforce transformation matches that, and I'm assuming that vacancies get transposed into the real, but just so I'm clear that there is no increased establishment at revenue cost that comes out of this, that would be just helpful to understand.
That's absolutely right, Richard. So there is no plan to be an increase of revenue costs for establishment, which is why we're working to the age-related national minimum wage, so that the grant covers fully the cost that the trust will incur. The Kickstart programme aims to look at challenging us to think and model our workforce for the future to be much more resilient, especially when we look at our age profile. And across all system partners, we have a significant gap coming because more than 40% of our staff across all system partners are aged 55 and over. So we do have to do things differently, and we do have to start to plan differently. Part of this relates to the work that we're doing with our school ambassador programme and our work experience team. Because we've now rearranged our programme to target areas of deprivation in Cornwall first, so that we can start to improve the health benefits of those communities. But also what we have seen is that most people, most of our communities do not know the number of roles that we have. People traditionally think doctors, nurses, and then they stop. Actually, we have, across all of our partners, we have more than 100 roles, and so it's making sure that we make those as accessible as possible, and making sure wherever we can, we match up skills and competencies with those people, because a number of the Kickstart applicants that we've seen already have tremendous experiences and skills that they've already attained. So how do we align those to our roles and look differently at being creative for workforce transformation?
Thank you, Kerry. That's very well made points. And if Kate and Carl would be kind enough to be as brief as possible, that would be lovely.
On mute, Kate.
Do you know, people have been trying to do that for years, Carl, and it's just a computer. I just wanted to draw all of this together. We're an anchor organisation. We're sitting in a county where there's going to be more and more redundancies or less work, however you want to look at it. And our biggest improvement in health and our biggest aid towards reducing inequalities in health is employment. Public sector wages are good in Cornwall. So that's the background to this. The opportunity we've got as an ICS, and do you remember I said at the start in my things that we need to start looking at, how do we simplify the governance so that for a few things that we intend to do in our last year of being a shadow ICS, that we can have some way of delegating responsibility for some things to a board. Paul and I were having that conversation yesterday with our other statutory partners, because that's our segue into transformation. And for me, if you then took this and you added in our meaningful activity coordinators, and you go back to thinking about me being 85, living on the Lizard, still being 19 in a body that doesn't work, maybe a community-based version of a meaningful activity coordinator for a skill set and a role title we haven't got yet, but we've got an army of people that we could be starting to give them expertise and training to get a new workforce. It hasn't got a name, it's not in a professional silo. It is a mind, body and soul worker. And that's where I think the ICS and our workforce models as part of our, I've run out of steam now, our model of care development is really important. So this small thing, I think we need to use this as a test of change for what we can do in Cornwall. How would we get the governance right? Where do we set our ambition? Is this really a partnership, or is it just RCH doing something on its own? So I think all the questions are right, and I think, Kerry, we need to find a way of pulling all that back together so the richness of the debate and the discussion becomes the platform for the project, and then we can measure ourselves against those outcomes.
Thanks, Kate. Carl, you, and then I'll give Kerry the last word as briefly as possible.
Just touching on both the financial risk and one or two of the other points that colleagues have made. Having assessed this, the position that we find from a finance perspective, they're very supportive of, and it's very low risk for the period of time that the grant is available. But of course, this is as I understand it, Kerry, a 6-month programme. So of course, what we need to make sure is those individuals that we benefit from and they benefit from, what the next stage is after that 6-month period, because of course that would be a financial risk, because there's no cover if those individuals were to stay on the payroll.
Exactly, Carl. Yeah.
So those we will absolutely monitor that, Carl, because our whole aim during those 6 months is to repatriate people into a permanent role and a vacancy of their choice, but with support and the pastoral support that comes with that, because we know already from the people that we're seeing, people are making different career choices now because they've been made redundant in some instances related to COVID, but we are able to attract a really high calibre of applicant, and they have skills that we don't have in abundance in our workforce already. And so we want to really work with them around the types of roles that they want to go into, rather than us trying to pigeonhole them into certain roles that we would like them to go into. But we will absolutely do the return on investment evaluation piece of how many people out of our 148 are we able to retain, and the programme actually runs until December 21, and we are able to top up if we're able to keep that, because my plan would be that we do our 148 we've been allocated, and then we continue to roll that forward, so we're constantly taking new people on.
Thank you, Kerry. This is an absolutely excellent piece of work. I'm going to stop us here. Can I really thank you and your teams for putting this together, and also the Department of Work and Pensions. It's absolutely what we need to be doing, and endorse the points that Kate is making. So could we, in the chat box, please put that we approve the acceptance of the grant for the Kickstart scheme at a value of 1.131 million. And thank you, I need your approvals. Now, while you're doing that, I just want to say 2 things. One, we are running significantly later than we've ever done before. That's not to say we're not having a great debate, but I really would like to ask that questions, comments and responses can be as succinct as possible, because it's important to hear them. The second thing I want to suggest, with your agreement, is that we take item 14, the freedom to speak up, now, because Clarissa and Joe have been with us for a little while, and I'm sure it's been really fascinating for you, but it's horrible waiting to speak, isn't it? So if we take 14, then we take 13, because Louise has also joined us, and then I'll have a review of whether we do need a short break, and then we'll take 12 after that. So apologies, Kim, but I have given you the heads up on that. So where we are then is item 14, freedom to speak up, Guardian Q3 report. Oh, I've got horrible echo. Thank you. We've got Joe Burton with us, who is our freedom to speak up Guardian, and we've also got Clarissa Lidder, a member of staff who has previously spoken up and is prepared to share her experience. And as I said, Clarissa, you're very welcome. I'm very grateful for you in doing this. But over to you, Joe, to introduce the item.
Thank you, Chair, and also massive thank you to Clarissa from me. Hearing her story here today will really bring alive speaking up in our hospital. Before we listen to Clarissa, I just want to pull 3 main points from my report. So firstly, our index score of 75%. We need to improve this score. It tells us that our speaking up culture is not as healthy as we all want it to be. Our colleagues are telling us this through our staff survey. So obviously we will get a new score soon, because obviously we've only just had the results of our last survey, but really important to bear this in mind. Secondly, we really must continue with energy our cultural improvement work, of which freedom to speak up is such an integral part. So I taught a session this week on our Being Brilliant bite-sized on compassion, civility and psychological safety. It was really great to have some open discussions with colleagues, and we discussed how it felt to speak up here. I think these sessions are great for getting a sense of how colleagues are actually feeling at the moment. And what I gained from that session was a real strong sense that things are feeling different in the hospital now, but in some pockets of our hospital, things are not feeling so good with regard to speaking up. And then just the third point, I'd really ask the board to support in making the new 3-tiered training system from the National Guardian's Office mandatory. This training will benefit all staff and really give the message that we as a trust are committing to our culture around speaking up and making it as good as it possibly can be. Managers in particular play a key role in speaking up and fostering that culture. So the listen up training specifically for managers will give them the tools to enable them to effectively respond and deal with issues when they are raised to them. Because obviously it's not just me that receives speaking up concerns in the hospital. There'll be lots and lots of conversations going on every day, and it's how we do that, how we always remember to thank people, really feed back to people quickly, and listen to all our staff, no matter where they work and what role they're doing. And I guess any questions from anyone before we hear from Clarissa?
Joe, if I could just endorse what you said about the bite size being brilliant, because I've been involved in that too. And before you joined us this morning, we were talking about kindness and enabling people. So your points are really well made. Thank you. Any other questions for Joe before we bring Clarissa in? I think we want to hear Clarissa, don't you?
I do too.
Go ahead.
Can we thank Joe too? So, you know, before we had Joe, we would never ever have been able to support Clarissa like she has been supported, because we wouldn't have believed her. We'd have moved her around, we'd have labelled her, we'd have made it really hard for her to tell her story. So we may still be on the, I don't know, the starting blocks of freedom to speak up being part of what defines us. But I think Clarissa's given us some things to look at as well, and the role of mediation, early mediation, not informal parts of whatever's early mediation. I think it's something that maybe we could focus on practically. So thank you, Joe.
Thank you, Kate.
Thanks, everyone.
Thank you. I completely agree with you. And I remember too the days before we had you with us, Joe. I think you clearly supported Clarissa so brilliantly, and I know you don't want thanks for that, because I know you do your job because you do it, but it's there, and I'm grateful for what you're doing in the whole trust with your team. I'm going to suggest, board, that we do move to noting the Q3 report from Joe, that we endorse the Guardian's recommendation to make new training from the National Guardian's Office mandatory for staff, that we note the current index score for freedom to speak up and comparative position. But I'm thinking I would like to propose, Sian, help me if I get this wrong, but I wonder whether we could just add one more thing, which is what Kate has just said, that we look further at how we teach mediation as well as management. I'm not sure what the language is, but perhaps if board would accept that, you would note and approve the Freedom to Speak Up Q3 report. If you could do that in the chat, and I've got a second proposal for you. My apologies for time, but not apologies for the time given to that item. I think it was really important. I am sorry that Louise, you've been waiting for ages. So may I propose, board, that we take Louise's item 13, infection protection and control, and then we take a very short break, like 5 minutes, and then we take the Ockenden report and the rest of the board agenda. Louise, I am sorry you've been waiting so long, but if you could give us your report, as you always do, taking the fact that we have read it, and we'll come to questions after that.
Thank you, Chair. And obviously, I appreciate the time that was taken with that previous agenda item, really important. So I'm presenting the Infection Prevention and Control COVID Board Assurance Framework and the NHS key actions with regards to COVID-19. As you say, accepting people have read the reports. The NHS England have produced the board assurance framework so that organisations can assure themselves that they are complying with all the relevant COVID-19 guidance, etc. As you can see, there are 10 key areas that the board assurance framework focuses on, with a number of key lines of enquiry within each. For me, there's probably just a couple of things to highlight from that. In terms of section number 2, one of the key lines of enquiry with regards to cleaning. Through our outbreak meetings, we have identified that cleaning frequencies, particularly around keyboards, have not always been as they could be. We have now introduced a daily team brief, and that's being further reiterated today at our internal incident command and control meeting at 1:30 today. With regards to section number 5 on page 222, rest facilities have also been identified within our outbreak meetings as not always available for staff to socially distance as well as they could, and I know that Ricky, our Director of Estates, is looking and seeking to address that. The other item is on page 227, and with regards to the 2-metre social distancing, we have taken steps to try and achieve that. Where possible, we move the furniture to ensure that the patients are socially distanced, and to support that further, we've introduced something called Mediscreens, which is a plastic barrier in between the beds. So I think that's the key things I wanted to pick up from the board assurance framework, and then just quickly move into the key actions. That's just a very brief summary that was introduced after the BAF, because the BAF came earlier on in the pandemic. The key actions are just a very brief summary for boards to assure themselves. There are a few additions to the 10 points from the BAF. It includes staff testing, patient testing, and then there's a section there as well for the system review of how COVID is progressing within the various organisations across the system. So I'll stop there and happy to take any questions.
Thank you, Louise. And just to note, as Kim has in the chat, this had a good discussion at QAC this month. However, I do not want to prevent questions. I think I love the way your voice sings out in your reports, Louise. I can always hear you speaking when I read your reports, and I think it's been a really helpful report to me. And I think it's page 198, where you say the trust is in the main compliant with many of the key lines of inquiry, and then tell us what the gaps are, and then obviously the data tells us the rest. So I find this a really helpful report, actually, as ever. Colleagues, do you have any further comments or questions? Yep, I think I've got Ruth here, if I'm not wrong. Can't see you, Ruth. No, it's Robin. Sorry, Robin.
I just put the thank you, Chair. I've just put the comment in the chat that whilst not specifically related to this report, it's really important that we acknowledge the whole IPAC team. The work that you've led your team with, Louise, has been absolutely outstanding. And I mentioned earlier the 4-phase plans, the IPAC thread that's through those plans. I sleep at night knowing that the influence that you've had on those plans is in there. So for me, to you and your whole team, I want to say thank you.
Thanks, Robin.
Kate, you would like to come in?
And I'd quite like to pick up, the cultural change from our first peak to our second peak, when people were wanting to argue the toss with IPAC around, when you would say that you're just purist, to now we cannot do anything without an IPAC view on how it will be managed. I think that's massive, and that's down to your leadership and that of the team. There are some things in here that still bother me. When we've got tired staff who we can't rotate out of areas, we can't give them a safe staff room to have a rest in, and then we get a nosocomial infection. It doesn't come as any surprise to me that that happens, because we can only stretch people so far. So I know Ricky's on the board picking up some of those practical things about safe spaces to just breathe out. Particularly if this is going to go on for a bit longer. So that's less about you and more about us responding in a way that makes it easier to be able to keep us safe. So I echo what Robin said. You're fab. Thank you very much.
Thanks, Kate.
Thank you, Kate. Thank you, Louise. Alistair.
Yeah, so I just wanted to say thanks as well to Louise, but also just to not to foist more work on her shoulders, but this sort of epidemic is going to come again and again, I think, in the future, and the way that we're building our future buildings is going to have to be IPAC sensitive and IPAC infection safe. So that golden thread of infection prevention is going to have to be woven everywhere through the fabric of RCHT and the system. And I think from you have a relatively small team, Louise. I just wanted to say thank you, because you do a lot of really important work.
Thanks, Alistair.
Thank you, Alistair. Kim, I think you wanted to come in.
Yeah, I think under Louise's leadership, having the integrated infection prevention and control team across both RCHT and CFT has been critical, and that growth now, how we support in care homes with our system partners. But Louise and I are really mindful. Someone said the other day, vaccines here will be soon out and about and flying and being back to normal. Louise and I, with a little bit more pessimism, which is unlike me, are like, we're 11 months in with probably another 11 months to go. So we're closely monitoring what our team composition will be like going forward, noting the pressures that the IPAC team are dealing with, but making sure they have resilience as well.
It's not pessimism, Kim, it's reality and realism, and it's good to hear you saying it. I think I totally endorse the point about teams. Karen, would you like just briefly to make your point?
Yeah, it was only really to say I don't think we should underestimate the value of having access to that advice 24/7, because when you're a manager on call or an exec on call and you get a phone call at 11 o'clock at night saying we need to move patients around because we've got to free up beds for people coming in through the emergency department, knowing you've got somebody who's expert who can tell you what the right thing to do is hugely valuable.
Which is why we need a bigger team, because Louise Dickinson has been working 24/7 for the last 320 days. So we do need to make sure that we build the team for resilience and longevity, not that we squish Louise into a corner.
I think I've had 2 weekends, Kate.
Oh, that's all right. I don't know what I'm going on about.
No, I know.
I'm sorry, terribly generous.
But more seriously, actually, on that point, I think we need to ask, I'm not sure who, probably you and the execs, Kate, to take that away as an action, to just be sure we are looking at that. You probably are, but I think as a board, we would like to know that, I mean, the last 2 items, Louise, as you can see, are all around, are we putting our resource in the right place? And if that's okay with you, Kate, perhaps we could take that away as an action, just to have another look. I know you do all the time.
So it's a risk register thing now as well, isn't it? So the IPAC falls over, the whole hospital's not safe. So yes, we'll take it away. And the same with us being a mediating organisation. We need to skill people to be able to be the people we want them to be, rather than just say we've changed our minds, we'd now like you to be like this now, please.
Louise, you've heard and seen the thanks, heartfelt thanks to you and others who keep us safe, and I know that you always do. Formally, I'm going to ask the board to note the assessment against the infection prevention and control board assurance framework and the mitigations in place to address any gaps, to note the board's responsibilities with regards infection prevention and control practices and testing as part of the COVID-19 response, and to agree Kate will take an action to look further into the whether these areas are sufficiently resourced, and bring a report back. Please could people indicate in the chat that you are happy to note that and agree the action being taken. So while you're doing that, it's 25 to 2. We were due to be taking questions from the public at 22. So I've had some conversations with various people, Kim in particular. I'd like to propose, with your agreement, that we take a 5-minute wee break, as we say in Scotland, and come back, if you could, at 20 to 2. And we will then take the Ockenden report, which Kim has said she thinks can be taken relatively rapidly, although it's really important that we take it. Thank you very much for taking the time, even though we're running a bit tight. So back at 13:41, please. Don't forget to turn your mics off.
Okay.
Thank you, team, for being back on time. Kim, are you there? I think Kim may not quite be back yet. I'll text her. We're just waiting for Kim. She seems to have been detained. I'm sorry. I'll give her a ring.
Sorry, Maury, there was a queue for the restroom. And we had to socially distance, so I do apologise if that's a little bit too much information, but might excuse my tardiness a little bit.
Not at all, Kim. I knew there'd be something that would have stopped you. It didn't occur to me that that's.
Thank you. So if I take this paper, there you go, I can hear myself now. So if we take this paper as read, the Ockenden report, as everyone knows, and there is a link to the full report, makes very sobering reading about maternity services and how we need to relook at the framework and the essential care provided nationally within maternity services. Now, there are 7 what they call immediate and essential actions, and on first looking at it with the maternity team, they are doing quite a lot over and above what I believe is sustainable in the long term. So you will see, no surprise, we have absolutely gone through it with a fine-tooth comb again. We have treated it as we would a CQC action plan. So there are 18 actions required to be able to meet all 7 criteria. Now, one is red, and it will be read nationally because the role of the advocator has not been released yet. So we could grey it out and say not applicable at the minute. We're choosing to be hard on ourselves and make that red. We will keep abreast of when the roll comes out, and then of course be able to apply it. We have 8 amber and 9 green. This will be monitored through the maternity, women and children's governance boards. It includes the neonates and the maternity champions. Both myself and Sarah Newton are the board champions, and Sarah and I have already had a meeting. Meetings will be going into the diary with our clinical colleagues and our governance to make sure that we are able to fulfil our roles. Sarah is a good example. Her action was amber. It will now go to green now that she knows what she's let herself in for. And this will be very, very closely monitored and come through to board in many ways, reporting SIs, progress against our compliance and in line with Saving Babies' Lives and CNST. And I will leave it there.
Thank you very much, Kim. I'm having a bit of trouble with my Wi-Fi, which is why I've turned my camera off for a minute. Sarah, did you want to comment at all, Sarah?
No, I've got nothing to add to the report. No, apart from the fact that I'm very delighted to be working with Kim on this really important piece of work.
Thank you. Colleagues, are there any other comments for you? In which case we're asked to discuss and reflect on, in the right report, whether the mechanisms are effective. And we're asked to note the response in December at 2020 of the immediate actions and note the further actions required to meet compliance. That is, can you please indicate in the chat?
There are a number of questions, Mari, looks like.
Thank you, Paul. I can't see because of my video.
Sorry, Mary, the first question was from me. So I remember back to our section 29A warning notice days for maternity when we reg rated self-assessments against national standards. So I know you and I have signed a letter off, Kim, but I think it's probably worth going through the robustness behind the reg rating and the internal controls so that we know that the reg rating is in a place that we as a board would expect it to be based on what we're receiving today.
Absolutely.
On the assumption Mari can't see this, Richard.
Sorry, it's the question. I was looking at the action plan, and there's a number of those are related to sustainable funding. Is that additional sustainable funding that will come through either a contract, or is that us finding the sustainable funding?
So at the moment, Richard, it's us finding sustainable funding. I suppose it is about how we use our money that we gain back from compliance with CNST as well, isn't it? I do think there's an opportunity as well to have a look with the current changes in women and children, what's new in the workforce and how we can use that more effectively, but most of all understand what especially the increase in our consultant PAs are.
Next year is going to be incredibly tight for money, so one of the things that we do need to be really clear on is where are our services where there are compliance standards that mean that we can't reduce our service away from national guidelines. And now in the past in this trust we've done that, which is where we got into trouble around our 929 warning notices. So I'd like us to be really clear about what cannot be moved, what could be removed if, and what actually is a made up rule, regulation, guidance, workforce that would allow us to do full transformation. And I don't think we're sighted on that yet. So this will be a cost pressure, I think, Carl, won't it, going into 21, 22?
I think the answer to that's yes.
Yeah, I think so we should be clear about that. It will be a cost pressure, and we will have to meet it.
Thank you, Kate. Who else there? Calvin.
Yeah, Kim, there's been a couple of mentions of Ockenden report in some of the digital forums, obviously, where we're collaborating across areas. Be really keen, obviously, to make sure that that's linked into a clinical working group. So maybe that's a conversation that we should have in terms of a join up there.
Yeah, we've been speaking to Liz, Calvin, but there was going to be a wider meeting involving yourself.
Thank you. In the interest of time, I'll read out Tom's comment that we need to build the required clinical and operational workforce models into the operational policies that go into the new build for women and children's, which I think is a given, really. So that's good. Right then. So, given that Mary read it all out before she left, are we happy that we've discussed and reflect on the Ockenden report review? and note the RCT's response and also note further required actions. If you could indicate as ever, please, in the chat line. I'm having problems with notes coming up now as well. Thank you. They're coming through. So must be a glitch in the system. It's very slow coming through today for some reason, but anyway. So thank you, Kim, on that one. Much appreciated. So I think we're back to the agenda where we should have been somewhere else about half an hour ago, which is moving on to Bernie, I'm assuming, on that page, Director of Integrated Governance. Take us through the Board Assurance Framework and Corporate Risk Register.
Thank you, Paul. I'm going to take the paper as read, but just take you through a couple of areas that we discussed, in particular at the board informal on the 28th of January. So on page 256, in relation to our BAF, we took an action that Robin and I would review the COVID-19 related RCT risk, which we have undertaken, but we will need to review that in light of, so this report was written before the new board data came out, and the subsequent COVID update in terms of deterioration in terms of our waiting time, so that the COVID-19 RCT risk will increase as a consequence of the information that's been reviewed. Likewise, we took an action through audit and risk to review the health and safety strategic risk at the Trust Board informal, and in light of the discussions that were had there and the additional paper that's going to board and committee, that risk will be reviewed in more detail post this meeting. Page 261 highlights our current COVID-19 related risks, which we include alongside the Corporate Risk Register. There is a new risk in relation to 7927, which Robin referred to earlier, in relation to testing capacity, which will be further mitigated with the introduction of the further SAMBAs and 24/7 testing. And then the only other area I want to highlight is when the Corporate Risk Register was presented at the Audit and Risk Committee earlier in the month, there was concern in relation to the risk on page 264, which is risk 7302 in relation to our multiple statutory breaches in relation to radiation and control of radioactive contamination. All of the short-term mitigation has been undertaken by Trevelyan Foy and his team. The further action that is required is capital investment, which Paul, Richard, you will know was discussed through finance and performance and also through building brilliance. So that business case has been put forward and has been put forward for prioritisation in terms of this year's capital programme. And Tom, I don't know if there's anything that you want to add to that.
Well, just to confirm the position that you've articulated, Bernie, really, it went through building brilliance. The need to significantly upgrade our nuclear medicine facilities and environment has been a risk within the Trust for 2 to 3 years now, and obviously due to that duration of time, that risk has just increased in terms of the non-compliance of regulatory standards. So I think we have no choice but to now invest in this and to correct it. It has had the approval of Building Brilliance, the investment committee, and the capital that we need to spend on this has been profiled over the next 2 financial years. And in terms of the next financial year, Carl and I and other execs have gone through that as part of the new capital programme. Thank you.
I'm happy to take any questions.
Thank you. Are there any questions while Mari's trying to sort out her Wi-Fi bits, I think, still?
Can I ask a question? So what's the actual risk to people receiving ionising radiation treatments from us at the moment?
It's to do with preparation. Just step in on that one if I can. I think it's to do with preparation as much as anything else. It's all still controlled. It just needs to be brought up to current standards more than anything else.
So I think we should say that, because it sounds like we're doing it for the regulator. We're doing it for our people.
For us.
So yes, we have to be regulatory compliant, but we have to be regulatory compliant because we are the best provider of healthcare in Cornwall. Therefore, our facilities should be the best for our people. And this just reads like the case in a regulatory visit.
Good point.
Old RCHT rather than new RCHT.
Yeah, the control of radiation in any radioactive environment is very, very well controlled generally, but there are facility expectations which are the bit that we're falling short on at the moment.
Yeah, so the issue with Kate's absolutely right, of course, but the issue with this is that if we didn't correct it, the regulatory impact would have a direct impact upon patient care. So the regulators would close down our nuclear medicine facilities. That would take away our ability to then treat patients that require those. So I think that's the missing narrative, perhaps.
Yeah. But arguably so they should. If we're not good enough, we shouldn't be doing it. So, and it's that bit that's the risk. We need to be good enough for our people by having whatever it is in place. And then my other question was, can it wait 2 years? Just
my view would be I don't think it can, but so
we need to go back around the block for the phasing then, don't we?
It's not waiting 2 years, sorry. It's a capital programme that's profiled over 2 years. So works will start in the next 12 months.
Finished within a 24-month timeline.
Why don't we don't have the detail available.
Let's take it offline. We'll pick up and we'll bring clarity back.
Offline.
Yeah.
Okay. We had a couple of questions coming up, one of which is Mari, which is quite interesting. You can invite yourself to talk if you like.
Thank you, Paul. Thank you for your assistance. I suggest you go on to the end of this item. I apologise, my Wi-Fi went. And forgive me, Bernie, because I may have missed this and you already covered it. So I just, on page 257, Brilliant Care 1.4, risk 6418, I think there might be a typo, or I've not read it right. And it's not a big point, other than that if I'm not understanding it properly. It says there is a parent risk that the Trust's RTT performance. I think that probably is meant to be apparent. Is that right?
Apparent.
I was reading it and thinking, where do parents come into this? But I thought they might actually. So thank you for that. And then there's the other question was on risk 3754, where you helpfully indicate the way the text has been changed, which I did find very helpful. And in that particular risk, you have changed the text to take out staff burnout. So it said sickness and staff burnout, and it now reads you've removed the staff burnout, which is really nice to see if that's the case. But I was a bit surprised in the circumstances of all the extra things people are doing. So could you just help me understand that?
So, in terms of our, I think there's a corporate risk in relation to staff burnout that we need to look at and review in terms of what we have in place. This was more around how we manage our case mix in terms of patients, and in particular about how that commitment that we made in terms of providing equity to all of the surgical case mix in terms of our recovery programme. So that's why this was amended for that specific piece when we went into the first recovery phase.
That's very helpful. Thank you, Bernie. Thanks, Paul.
Okay, thank you. Tom, do you have anything further to add? Or was that an earlier one?
That was an earlier one. Thanks, Paul.
Okay, thank you, Tom. If there's no other questions on that basis, we can conclude this item. We're asked to note the position in respect of the compliance with the Environmental Agency and such like, as we've discussed, to approve the changes made to the corporate risk register and also the changes to the strategic risk following executive review over the past few months. Are we happy with that? If we are, could we please note that in the message box? Thank you very much. I return the helm to our chair.
Thank you, Paul. You'll have to go and be the navigator though, huh? Thank you for that. Okay, that brings us to item 16. Bernie, you again. We would at this point invite you to reflect on any matters from today's discussion may require escalation onto the board assurance framework, strategic risk or corporate risk register for the operational risk. Have you noted things down?
So I think the main piece that picked up today is around recovery and resilience in relation to the next phase when we come out of wave 2, and I will review that with Kerry and Robin in terms of our current risk in relation to that.
Thanks, Bernie. I'm wondering, I don't quite know how to put this, and I might be wrong. I'm wondering whether there is anything coming out of the discussion with Clarissa around whether or not we've got risk that our managers aren't sufficiently able to do the mediation. I'm not sure, I'm not wording it well, but I don't know where it would appear, but there's something about making sure we've got enough listening and believing in our management for our staff. Kate, sounds like you might be going to help me.
I was going to talk more about that we teach people how to mediate. We don't teach people how to mediate, we teach them how to manage and to investigate and to all of those fairly at times pejorative and judgmental things. We don't teach them to mediate, and that's what Joe's doing quite a lot of. But with mediation comes supervision. So we'd have to have a mediation framework that it's sat within, and people would have to have coaching skills too. So I think we need to do logs that we probably haven't got what we need, but then we need to work out what we put in place. And I think probably in designing it. Kerry, do you want to come in?
Thank you. Yeah, I think Clarissa joining the discussion would be helpful. This was fundamentally part of the reason for the pod restructure, because I had been made aware from a number of colleagues, such as Clarissa, that the employee relations team was focused around always having to have somebody to be vengeful against. So we've moved away from a standalone employee relations team to a colleague experience team. We do use early intervention. We have totally moved away from everything that has to fit into a formal policy somewhere or another. We do have trained mediators. We have more mediation training coming, and actually MJ, as our lead for the people experience team, coordinates and runs that service offering, so we can definitely expand it and make sure it's part of our leadership development.
And Maury, I was just going to pick up in terms of our strategic risk 73544, which is around creating a safe environment for colleagues to feel supported to speak up. We will look to build in the issue of mediation as one of the additional actions and seek assurance around that. So I'll work with Kerry on that.
Thank you. Are there any other points for Bernie from today? Okay, so I think we have identified some risks, and Bernie, you're going to take those away. I'm grateful for that, which brings us on item 17, whether here we're asked to note the board calendar of meetings. Did anybody want to say anything about that? No? Sian, did you want to comment at all? No? Okay, that's fine. Thank you very much. Which brings us then to questions from the public, and over to you, Sian, for that item, please.
Thank you, Chair. So far, as I start this, we've had 5 questions from members of the public, and we've had 2 pertinent comments as well, which I'll read out. So we did receive 1 question before the meeting. It was actually in relation to, it was a follow-up from the December board meeting where a member of the public had asked about what a guarded outcome means, and Alistair, as medical director, had responded to say that COVID-19 can leave people with significant deficits, and so somebody has written in to ask, what does significant deficits mean? So they've asked, sorry, I can hear myself. Could everyone mute their mics? Thank you. So the questions asked were, what procedures are undertaken for patients who are being discharged with significant deficits, i.e. are GPs informed of the need to see the patient if they have a risk of thrombosis? Should the patient be discharged? Linked to that, did deficits mean that the more patients who were discharged to care homes when they previously been living at home? And for patients who were discharged with these deficits, were the necessary care packages available for them? And if so, were there any problems in care packages being organised? So a written answer has been provided. The question came from Nigel May, and the written answer from Alistair as medical director is as follows: all patients are assessed by their clinical teams during their admission and offered follow-up if necessary, whether that's with a doctor, other clinician or therapist if rehabilitation is needed. This is and always has been standard practice, and where care needs or packages are identified, these will be put in place. Primary care, the patient's GP, will normally be informed of any concerns or on discharge and ongoing needs. Patients who recover from COVID-19 can be left with various problems, both physical, often cardiopulmonary, and psychological, and these are sometimes referred to as long COVID. With the clinical commissioning group and local health and social care partners, we've set up a long COVID pathway into which GPs or other health professionals can refer people so that these long-term effects of COVID-19 can be managed appropriately. So that was question 1. Question 2 is from Jane Bennell, and Jane asks, following on from the Chair's question to the Medical Director about mandatory training about learning disabilities and autism, what has been the attendance at the recent training event, and what formal and informal, negative as well as positive, feedback has there been from medical staff? So Alistair, if you could respond, thank you.
Thanks, Sian. So I have spoken to our learning disability and autism lead about this morning, and these sessions were specifically set up for doctors, 2 sessions in January and 2 sessions in February, which haven't happened yet. In the 2 sessions in January, we had 35 doctors attended those sessions, and I think that's, in terms of that being right in the middle of our pandemic surge peak, I think that's pretty good attendance, but we've certainly got more to do. In terms of the feedback that the leaders talked to me about, there was no negative feedback from those sessions. In fact, there was a lot of really very positive feedback, and especially around the learning that was derived from our in-house experience of managing learning disability and autism. So there were in-house examples of where things haven't always gone right, and the staff apparently found those very, very useful and commented on those.
Thank you very much. Thank you. Another question in relation to the learning disability training, actually, from Rachel Bradford. In addition to Jane's question, who delivered the mandatory training for learning disability and autism, and what qualified them to do so? Is this training delivered from the Oliver McGowan model? Alistair, could you answer that one as well?
Yeah, so our in-house learning disability and autism team delivered this training. So this is built on evidence-based practice and lessons learned, as I said, from internal experience. In terms of the Oliver McGowan training, I've been informed that the Oliver McGowan model of training has not yet been finalised or published. So we haven't been using that particular model. And I think if this is the Rachel Bradford who is known to us in the trust and to Kate, then we always welcome any feedback or any carer involvement in our delivery of training and carer feedback. So if they do want to come back to us and ask any further questions, I'm very happy to have a conversation.
So we'd be really happy for constructive feedback that could make us even better. Indeed. So if there's ways that we could amend our training. So if it is the Rachel that we know, then please get in touch.
Thank you very much. Next thing I'm going to read is a comment. I just thought it was pertinent in relation to visiting. and the restrictions that Robin outlined earlier on, and there was a question from a member of the board about how those restrictions are communicated, and the comment was as follows: letters have not been changed in many instances for patients to let them know that they cannot have someone to escort them to their appointments. It's a real issue at Trelawney reception at the moment, and it's not getting any better, unfortunately. And I just wondered, Robin, if you wanted to comment, make a comment back on that.
Of course, thank you, Sian. So I would be really interested if anybody's got any examples where our letters haven't included the updated guidance. Our centralised system, which delivers the bulk of our appointment letters, absolutely upgrades each time we make a new decision. There is a chance that some of our more local department appointment letters aren't being upgraded. So I'm going to pick that up with all of my managers after this meeting, but I would welcome any examples so that I can make sure that they're sorted. At the same time, we have just been working with our health and safety team and our estates team and security advisors to make some changes to the way the Trelawney reception works, so that we can flow all people, visitors, staff through that area in a much more efficient way as well. So there's a couple of things changing in Trelawney, but I would really welcome examples of where our letters aren't right so we can get them right, please.
Thank you very much. Next question from Anonymous. There are a number of vulnerable staff.
I'm sorry, Sian, I apologise. I think Kim wanted to come in on that one.
Apologies, Kim.
No, that's all right, Sian. I think Robin just covered it. If we could just have definitive examples, because those are the ones we need to pick up because they come from local. I know, strangely enough, I've just had my outpatient appointment and there's a really helpful leaflet that absolutely lays everything out, and that's what we need to make sure everybody is doing.
Thank you very much. Next question from Anonymous. There are a number of vulnerable staff, quite rightly, given the current infection rate in hospital, working from home. They're working from home and not doing their usual or full role. After they've had their scheduled second vaccination and allowing a couple of weeks for it to take effect, will these staff be able to return to their usual duties, both to reduce operational pressure and for their own mental health? Kerry, would you be able to respond?
Of course, thank you, and thank you for the question. We're making really good progress with our vaccination programme right across the county, but we are only really at the start of it. So those colleagues, even though they've had their second vaccination, still do have a higher level of risk, and therefore we work very closely with our clinical teams and our occupational health consultant, and based on their individual risk assessment and their underlying health conditions, some of those staff won't be permitted back to work in frontline roles, but we do obviously review this all of the time, especially in line with national guidance, and as yet we haven't received any national guidance that says those restrictions can be lifted off colleagues, and therefore we'll take every precaution to maintain the health, safety and well-being of all of our colleagues.
Thank you very much, Kate.
We need to be really careful though, don't we, that even though you've been vaccinated, it just means that you are less likely to contract COVID. And if you do contract it, you're less likely to be hospitalised and to be really poorly. So whether you've been vaccinated once or twice, you still have to socially distance, wash your hands, wear a mask. And if we're asking you to shield, I suspect we should still ask you to shield because we're not in that position yet where we've got mass vaccination across the county. Do you agree, Alistair?
Absolutely do, Kate. I think that's a really important message. I think people's vulnerability to COVID is a mixture of both their own personal health needs, but also the prevalence in the community. And I've been having a conversation with occupational health about this. We know that when the prevalence in Cornwall went up recently to 300, then that prompted a review of everybody's risk score by the occupational health team, and that meant that a significant number of people had to then go and shield again who had been able to work in the hospital with appropriate enhanced PPE. And when the prevalence in the community comes down significantly again, then those risk scores will be re-evaluated, and some people may be able to come back to work and some people may still need to shield. So it's complicated and dynamic at the same time.
Thank you very much, Kelvin.
Thank you, Alice. I think
just to pick up on the point as well about people feeling isolated at home. So just to reiterate, we'd ask managers of people who've got working at home if they don't have facilities to allow them to keep in touch, because obviously we've been providing a lot of equipment so that people can still participate in meetings, do other forms of work, access all of the information we're providing. So if managers could make sure they let us know.
Thank you very much. The next is a comment. It was in relation to Clarissa's presentation to the board, and Anonymous states, Clarissa, your experience mirrors mine, nothing ever done. People give up the fight, sometimes leave. It seems to be a problem across so many departments, but no one wants to know. Moving the victim does not fix anything. I'm glad you had a good experience with freedom to speak up. Sadly, I did not. I just thought it was important to reflect that back to the board. The last question, I can't see any more have come in, so the last question will come to you, Kerry, from Anonymous. With core staff working tirelessly to help with COVID and the pressures around the trust, are staff able to use their annual leave, and will there be any scope to allow leave to be rolled over to the next financial year? And if so, how much leave will be allowed to roll across? Thank you.
Thank you, Sian, and thank you for the question. We have recently agreed that colleagues will be able to carry forward up to 10 days of their annual leave into the new leave year, because we know that some colleagues have found it much more difficult than other colleagues to take their leave. As a trust, we have constantly promoted taking rest and annual leave right the way through the pandemic, and we haven't, to our knowledge, stopped anybody's annual leave. Now, of course, there may be clinical requirements where some colleagues felt that they had to rearrange their annual leave, but there is national guidance from NHS employers, and we have followed that guidance. We've also done some benchmarking with other organisations and are taking the consistent approach to allow the carry forward of 10 days annual leave, and that's been engaged with our staff side chairs and is being communicated with colleagues. There's also a financial implication which Carl highlighted earlier, where we do need to account for it.
Thank you very much, Kerry. And Kate, you wanted to come back on the comment in relation to freedom to speak up.
So the person who's had a bad experience and through that experience has left, your reality and your experience is still really important to us. So I would just want to invite you, if there's somebody that you trusted the trust that you could come and speak with, then we will treat it in exactly the same way that we treated Clarissa's. So it's just an invitation. If you feel you want to take a chance on us and to have a conversation, then we're always here to have that conversation with you.
Thank you. Thank you very much. Mary, that concludes the public questions. Thank you. Okay, you're still muted, Mary.
Thank you, Sian. And can I thank members of the public very much for the input and the really helpful and thoughtful questions and comments. We value them, and may I just remind you about the Survey Monkey that's going to be put up for today's meeting. So colleagues, just before we do take a break for some sustenance, well, internal sustenance, we had plenty of mental sustenance today. Come to item 19. We always have this item where we have a think about what worked well today and what would it have been even better if we had done. So I value feedback from colleagues. And I'll say the first thing, which is we need to do better with our timing. I do apologise for it. I felt the Clarissa's item in particular, but one or two others as well, we really did need to hear Clarissa, but I'm mindful that other items have slipped as well. If it could be more effective, we needed to be better at estimating the length of time items are going to take, I would say. Kate.
So I think it's really, really difficult to have conversations like the one we had with Clarissa without knowing that she's all right afterwards. And this medium isn't a great way of doing it. So I'm going to follow up with Joe.
Thank you, Kate. Kerry.
Just on 2 points, please. To pick up Kate's last point, I have already checked in with Joe that she'd followed up with Clarissa before she went back to work, and Joe has done that. And then the second point is that I think we really need to hear more conversations and more people's feedback, like Clarissa, and brave colleagues that are willing to come forward and talk about their experiences, because it changes the way that we deliver our services. And we know that we've made some really good progress. And certainly for me, I know that we've refocused and restructured the People and OD team to be as supportive as we can be to all colleagues, but there is obviously still more work to do. And so hearing those stories, I think, can only be a positive thing. And how we share them and the lessons learned and embed those lessons learned right across the organisation, so that we do positively promote speaking up and the fact that we will do something about it.
Thank you very much, Kerry, and thank you both for ensuring that Joe and Clarissa are both okay. And I guess my thing on that is Clarissa may be okay, but she may become less okay as the day progresses, and I'm sure Joe will have that in hand. So yeah, I agree with the importance of hearing stories. Kim, you've just put something up there.
Yeah, thanks.
Yeah.
So I think it is key critical that we hear the stories, but I think we also then need to make sure that we've got that supportive time and that framework and have that time to discuss it, because I was really conscious as well that we were running really behind time and had other people waiting as well, but it doesn't detract from the importance of hearing.
Thanks. Thank you, Kim. Richard? You're muted. Kelvin, do you want to come in while Richard's trying to get his mute unmuted?
Okay, thanks. I just wonder if there's something around the way that we sequence the agenda that perhaps could help, because there are certain aspects of the agenda that are predictable, or you can use, chair's prerogative to speed them along. We absolutely were not going to do that with Clarissa. We had to hear everything that she had to say. So maybe we think about how we sequence things so that we can manage that.
Thank you, Kelvin. And Ruth has just made a suggestion which I was thought about too. In some of the work I do, it's so nice to pre-record something, because then on the day it's not quite so traumatic, and then perhaps the support can be built around. So thank you, Ruth. I agree with that. Richard, have you managed to unmute yourself?
You can tell me. Can you hear me?
You have.
Okay, that's good. Yeah, it seems to the processing of unmuting seems to be random. Apologies. I was just basically agreeing with Curry and saying the importance of those stories and the importance of that discourse as a real triangulation process for the board is so important. But it does mean that we are going to have to really focus our minds on the rationalisation of the agenda, particularly, I suppose, in relation to agenda items coming through from subcommittees, to try and find space for that. Otherwise, we will end up just being an increasingly lengthening an agenda. So,
thank you, Richard, for that helpful comment, because that was the point about the discussion in the board informal. Will committees talk about whether they do want to talk about the IPR in such depth, or should it come to board? So great. Anybody want to make any other comment?
Can I just make one final point? Sorry, we put it in the sidebar. So you can take the girl out of psychiatry, but you can't take psychiatry out of the girl. Once we invite people to start telling their stories, they sometimes tell more than they want to tell. So there is something about putting control with people when we ask them to talk about really emotional things. So the question mark for me is a full public board the place where you would come and talk about something that was deeply emotional? Or do we find a safe way in which you can tell your story and then say, can you miss that bit out? I really didn't want to say that bit. So I think Ruth's idea around recording it is a really good way of being open and honest and protective, so that people can tell stories in safe ways. I didn't want to get lost in the chat at the side.
You're muted, Mari.
Just about to thank keeps muting me, and then I forget that I've been muted. So thank you. I just was endorsing what you're saying, and thanking you for making that point more, Kate and Ruth. So that brings us at 2:25 to first of all thanking Pete Young and Hannah Webb for their excellent technical support as always. We couldn't do without you, Pete, and I'm very grateful for you meeting me. And so let's. The date of the next board meeting held in public is Thursday, the 4th of March. And to advise members of the public that following a break, we will move into our private session to consider matters deemed confidential as set out in the notice of motion at the end of the agenda. Thank you for your time and engagement. I would like to propose that we do take a 20-minute break. This would mean that the afternoon meeting would finish at 5:30, not at 5:10. Would anybody be inconvenienced by that? Because I think we probably do need the break. Any old thumbs up will do. One. Or is anybody wanting to take 10 minutes break? And yeah, I've had a few thumbs up. Well done for those of us who get thumbs up. And Sarah, I note that, and also I know Adam. I know there are two people that will need to leave promptly, but I believe we are sufficiently quorate for that to be okay. Plenty of hands and thumbs. I don't know how you do that moving one. Okay, so shall we come back at 2:45?
If you say so, boss.
I do. Thank you all very much. See you at 2:45. Don't forget your
meeting. It's in a different meeting, so it's not this meeting. Not this meeting.
I knew I needed you, Paul. I knew I needed you. Well done, everybody. See you on the other side.
Thank you. Bye-bye.